Anybody has a question you want to ask about the progressive aligners? Maybe some of you have tried it already or plan on it.
Yeah, you saw the comment from Alex about the template being a whole lot better than what he'd experienced, of course, at ClearCorrect and also Spark. And you know, for the placement of attachments, he was going to ultrasonic it the next time. Is there some reason for that?
You know, everything that is made of any plastics or anything like that can have a film on it that can cause things to stick to it. So I haven't heard about a lot of problems with composite sticking to the inside of it. But as far as having it just release more easily, I don't know. Perhaps we'll have to see what he says, but perhaps if he does a little ultrasonic with alcohol and finds that, oh, it releases a little bit easier, that might be interesting to see. But yeah, I imagine that to some extent there's a little bit of a bond that happens between the material of the template and the composites that we're using to make the attachments. But I haven't, you know, with ClearCorrect, we used to get such severe bonding that it would rip the composite off the tooth.
Yeah.
And we're certainly not having that issue.
Okay.
And then, you know, people have been using Spark are saying that the template is just really soft and malleable, and it doesn't feel very precise as far as placing those attachments on the teeth. So, you know, I guess this is a good time to welcome everybody and start off with. This is what I wanted to start off with was, you know, for those of you who haven't tried a progressive aligners case yet, it is obviously available here in the United States right now. Currently, we'd love to help you get your first case started if you haven't. If you are in Asia, Australia, apparently that is being signed tomorrow. So Miles, our CEO, told us that we have 2 thumbs up for having those on board for you guys, probably the end of this month. It might be the end of this month or beginning of September, but everything looks on track for having that for you. And then Europe will be just shortly behind that. And then Canada, we're still waiting for the FDA to approve. So what we're trying to expedite that. So it may be a little bit longer in Canada. But those who have tried progressive aligners, we're getting really, really positive feedback. People do love the setups that they're getting back. And that's, you know, one of the best features about the progressive aligners is the technicians, the experience that they have, the quality of the setups that we're getting back. People are really liking the template material that's being used to create the templates. Those are working really well. They are meant to be stiff and rigid so that those templates, the attachments can be placed very precisely on the teeth. And but they are trimmed in such a way that they should be a little bit easier to get off than some of the other ones out there. People have been really thrilled with just the look and feel of the product, and the patients have been very happy. So far things are going really well. If you haven't had a chance to try a progressive aligner yet, we want to help you. I just wanted to show you guys the box here. This is what the progressive aligner box looks like when it comes to your office. And so I thought I'd show you real quick what you see when you open it. So when you open these boxes, you're going to see some papers that have been included in there that somebody called today and had a question about. It'll have your patient's name on it. But the first one is basically just an attachments page. It's going to show you which teeth are going to get attachments and what stage. You know, the default is at the first aligner, but some offices like to set it at aligner number 3, which you'll see in the case we're going to present today for convenience for the patient or for the way the office flow is. So this will tell you what stage the template is to be used to place attachments on the teeth. And you can set this chair side and check those off when you have placed them to make sure you got them all placed. The next piece of paper is something that shows the features of the tooth. And so in this particular case that I opened here, they have bite turbos being placed at aligner number 8 through number 30. And so on this particular one, so there's nothing to do with the features. It's not like anything needs to be done as far as placing composite or anything. It just shows you what features are in the aligners at what stages. And lots of features available. We have bracket cutouts. Obviously, if you ask for a bracket cutout, maybe in a revision stage, you'd be adding brackets on certain teeth down at the gingival level to try to maybe straighten up a few spots using the aligners as a guide. So that would require you to place a bracket into those bracket cutouts and a wire into the brackets. We have button cutouts. And so if you've asked for button cutouts, you're going to probably be using elastics like we'll see in today's case. We're going to see some class 3 elastics. So if there's a button cutout, you're going to need to place buttons on the teeth in order to use those elastics. But the other features are just more for your awareness and the patient's awareness. Bite turbos, end trimming. Sometimes they cut off the distal part of the aligners when we're doing upper sequential distalization. And the reason why they do that is so that once you've moved the most posterior tooth back to its final position and start moving the other teeth back, if you have the distal wall of the aligner in place, you get pushback. And as the other teeth try to move back, there's going to be an opposite effect on that when you've already distalized to try to move it forward. And so cutting those, they'll cut it for you so that you don't have that pushback. They show if there's pontics there, they show if you have an eruption guide, so like a little space in the aligner that's supposed to be allowing the eruption of a tooth. They show elastic slits, power arm reservoirs, occlusal pad reservoirs, torque ridges, rotation ridges, intrusion ridges, all these great features that we have that we'll see being used in these different cases that Don and I will be presenting over the next several months. I have a message here from Bondu. Can you message Derek? He will be able to send you the link if you're having problems with the link. So if you, Derek, if you're listening, if you can send the link. Apparently the link that some people have are just going to the recorded version from last time.
Sounds good. Yeah, I'll send it over.
Thank you. The next piece of paper that's in there is one that indicates when and where IPR is to be done. So it indicates the specific tooth locations, the specific amount of IPR, and what stage is to be done. So these are to be kept at the box. You can, use these to check them off as you do them, and just in case somebody isn't making notes in the clinical chart, you at least have a record with this patient box as to when these things were done, so you don't lose track of that. And then inside the box, you're going to have a bunch of little packets that are in order that have all of your stages of aligners, that will have a template for placing your attachments. And you also have a patient guide that's going to go inside of this really nice looking patient box. It's a really nice box for them to take home. It's got a nice little magnetic closed lid on it. And inside of this patient box, they've got a little tool to help them get their aligner out. A nice little hook on it there so they can grab the edge of the aligner and pull it out. They've got some chewies in here. If you've never used a chewy, it looks like a cotton roll, but it's just a little rubber cotton roll shaped thing that the patient puts in their mouth and bites up and down on the aligner to help seat it all the way. And then also to, you encourage them to use this multiple times throughout the day, move it around and bite up and down. It moves the teeth into the aligner really well. A really nice looking patient case to carry their aligners around in. That's got the logo on it, and their aligners fit really nice in it. It's nice and slender. It goes really, slips into your pocket nice. It, doesn't take up a lot of room in your bag or purse. So yeah, we're excited, and people have been giving us great feedback. And if you haven't tried a case, we certainly want to encourage you to do that, and here to help you any way we can. So let me share my screen and let's get started on our webinar for tonight.
I have a question, Collins. Could you please point out to them where the numbering of each tray is so they don't mix it up?
Yeah, the examples that I have here, they don't have the
them.
printing on them, but the printing will be right on the front here. But each individual aligner will actually have, if you look closely, there'll be some little printing on the aligner. And so if the patient confuses certain aligners, if every aligner says upper or lower, it has a U or an L, and then it has a number that tells them what stage number that is. Because sometimes they, forget to put it back in the right envelope, but the envelopes will have the stage number printed on it. And each aligner has a stage number printed on it, as well as upper or lower for the patient. Yeah, it's a good question, Don. Thanks. Okay. All right. So this is a case provided courtesy of Dr. Weber Chen. We're very grateful to him. We'll talk a little bit more about him and introduce him in a slide that's coming up. But we're very grateful to him for allowing us to use these images and to show his work and Again, we'll talk a little bit about him in a bit. Also really grateful to Don McGann, who was the mentor, along with Amit Lala, who's the mentor for this case. And Don was the one that provided us with this PowerPoint and made all of the slides for us and the contents. We're grateful for him. And I'm grateful to be able to present it to you here. And so let's dig in and have a look at it. So just real quick, I showed these slides last time, but since I pulled out the aligners and showed you, just want to remind you that we do have, and we're not producing these aligners. Okay, so it's not like this is people working right here at the Progressive headquarters producing these aligners. We have partnered with the best company, in our opinion, the best company in the world at producing aligners, and using their designers, using all of their processes. And so they have fine-tuned this and customized it for us because we're trying to make this the best aligner available for the general dentist. Okay, so these are the best aligners out there, in my opinion, for the general dentist for lots of reasons. There is an online doctor portal. You go and access that at progressivealigners.com and use your SmileStream username and password, the same as your SmileStream, to get into your Progressive Aligners account. If you don't have a SmileStream account, just go to smilestream.com and create a free account. If you are a SmileStream user, there's buttons over on the left-hand side. You can see this P. There's buttons there. If you click that button from SmileStream, it just logs you straight in and takes you right into your workbench inside of the doctor portal and Progressive Aligners. We have lots of different products I highlighted last time, but just to recap real quick, there's a Progressive 10, Progressive 20, Progressive 30 products. Okay, each one of these limits you to either 10 aligners or 20 aligners or 30 aligner stages for your first set of aligners to accomplish the endpoints. And the Progressive 10 does not have any refinements or revisions available. So I'd be really careful with this product and only order this product on a case where it's literally just some very minor relapse, maybe on some front teeth, where you're trying to just get a few things straightened back up again. For somebody who maybe had ortho previously or just has some really minor movements they want to accomplish, because you're not going to be able to get additional aligners on these. And it does come with one set of retainers. So Progressive 20 and 30, these give you either 20 sets of aligners or 30 sets of aligners. Remember, each stage includes an upper and a lower. So we're talking about 20 stages or 30 stages, each one having an upper and a lower. These have a 3-year warranty. So during 3 years, you have up to 2 revisions or refinements available to you with an additional 20 or 30 aligner stages in each refinement or revision, and then 1 set of retainer. When you order the retainer in these products, that closes the case, and there's no additional refinements available to you. And for that reason, you may want to consider on most of your cases, this unlimited product, which gives you 5 years to finish. It gives you an unlimited number of aligner stages and an unlimited number of refinements or revisions to accomplish your endpoint. And then again, a set of retainers at the end. But if you were to order the retainers and then within those 5 years have some relapse and need some additional aligners to get things back, you can reopen the case and order more aligners without having to pay more for that. And then unique to us, we have this finishing product. So if you do braces in your practice and you want to do your braces and then take the brackets off without doing that fine tuning finishing at the end, or maybe the patient just wants them off, they're tired, or they have a wedding, or they're going off to college or something, you can, if you're within potentially 10 stages to finish up the case, you could get this discounted price to finish up the case. And that's available for people who are using the IP appliance from Progressive Dental Supply. So if you've done that, it gives you this option here. When you submit cases to Progressive Aligners, it's best to just click the button at the bottom that says choose product after treatment planning. That way the stagers and designers can set up the case the way that they feel, based on movement protocols, what's going to work the best, the most predictable. We'll find out how many stages it's going to take to get your teeth straight based on proper protocols. And then when you find out how many they're proposing, then you can pick the product that might work best for your case. There's a question here. Will the cleaning up of the aligner cause the printing of the stage numbers to go away from the aligners? No, the printing, if you clean the aligners, it's not going to take the printing off of the aligners. If you do find that, let me know, because as far as I know, that's not going to be a problem. And then again, Miles, our CEO, has really tried to make this the best for the GP, and so has placed discount tiers at levels that are achievable for the GP. Okay, so at the level that you're probably doing in your practice, you can easily hit some of these premier, elite, platinum, maybe even titanium levels and get discounts on your cases and be able to advertise that you are an elite provider for progressive aligners. And so this is a nice feature. I've already talked about the designers. Really, these are the best designers out there in the whole industry as far as their experience, their training, their understanding of orthodontic principles and how to move teeth properly, understanding what we're telling them. Plus, we've got our own protocols that we've asked for our stagers. Really great material, proven to be really effective, looks really nice, very comfortable for the patients. And we'll see the software again today. I've recorded some videos that we can look at me manipulating the software, but you'll see it's very nice software that you get to use to evaluate your setups and use doctor edit tools if you want to make edits to the setups, but really nice, easy, intuitive software. And then I mentioned the features a little bit, but lots of great features in these aligners that you'll see as we go through these webinars. And just want to encourage you to keep either attending as you can. We're going to try to move the times around a little bit to accommodate different people in different parts of the world. But if you miss one, go and watch the recorded. We'll always have the recorded version available to you to be able to watch. So let's jump into this case. We are going to be talking today about a Class 3 case. It's a pretty mild Class 3 case, which is the best type of Class 3 case to treat with aligners. So it's a pretty mild Class 3 case, but we get to talk about all of the different things that we want to keep in mind as we approach treating Class 3 cases with aligners. So this is a great one to look at. So the first thing we want to just call to your attention before we start looking at the records for the case is that whenever we have a growing Class 3 patient, we want to factor Class 3 growth into our predictions and into our setup. So those of you who are accustomed to using SmileStream and using DentalCAD to create two-dimensional VTOs or visual treatment objectives, we have been instructed and taught how to adjust the lateral ceph to add differential horizontal growth to the lateral ceph. That means we anticipate the mandible to grow more than the maxilla. That's why we're calling it differential horizontal growth. And so to try to predict and compensate for, the potential growth, we want to move the mandible in DentalCAD to compensate for growth, so that with the lateral ceph, when we create these VTOs, we've added growth into that. And not only does that help us to treatment plan correctly, but it also protects us if somebody sees our records, if we refer if the patient wants to go get another opinion and we send our records to another doctor, or if it's called into question for any reason, it's obvious that we've considered growth and that we've discussed growth, we've taken into consideration in our treatment planning. So we want to do the same thing when we're setting up these 3D VTOs or these 3D setups in progressive aligners. And the way we do that, which we'll see in this case, is we're going to ask for 3 millimeters of overjet as our endpoint. Okay, so that's a millimeter of overcorrection from our standard 2 millimeters. That's an ideal amount of overjet. Okay, so if the patient's growing, we're going to want to finish with 3 millimeters of overjet. So that gives us an extra millimeter. Okay, or this would be the same as asking for an extra millimeter of Class 2 in the finish. So rather than finishing as a perfect Class 1 in the posterior occlusion, we would want to see it a slightly Class 2 finish in the posterior occlusion. Okay, and some things that we're going to see today and talk about is the use of Class 3 elastics in these Class 3 cases. We didn't use it in this case because it's not a severe enough Class 3 case, but reverse headgear can be used and applied in aligner cases. Okay, so we can actually have button cutouts on upper sixes, and we can put a button or we can put brackets on the teeth up at the gum line. Gives us something to hook an elastic onto, and the patient can, in the evening, at nighttime, wear.
Yeah, his name is Colin. That's really nice.
He wears a dress shirt.
Let me just mute everybody here real quick. Let's see. I forget where I do that. Let's see.
I got it.
You
You're
got
good.
it? Thanks, Derek. All right. So another thing that we're going to talk about is using IPR, okay? Because sometimes we're going to use some IPR. We'll do some interproximal tooth reduction in the lower arch to help us get proper anterior overjet, especially if we're not going to be, or we're not able to achieve a perfect class 1 occlusion. And I've just added a note here. Be careful. Make sure that you're really paying attention when you're treating a growing class 3 with aligners. And especially if they have a strong width, especially if there's a lot of measured skeletal class 3. So there's a lot of potential for differential horizontal growth in the mandible. The case we're going to look at today is not a real strong skeletal class 3 case. It's very mild. But if you have a real strong potential horizontal grower, what happens is when we have our teeth coupled together, so imagine over here, if I have my upper incisor and my lower incisor, and I have overbite and overjet in the front, then as the mandible wants to grow, these lower incisors are kind of trapped underneath the upper incisors. And what we get is we get dental compensation for the growth. And so as the mandible grows forward, the lower incisors begin to tip backwards and the upper incisors begin to tip forward. So we get proclined upper incisors and retroclined lower incisors as the mandible's growing forward because of the coupled occlusion. But when we put the aligners in and the patient starts going through a growth spurt and having a lot of growth, they're not really coupled, okay? So they're spending the whole day with their teeth essentially uncoupled. And therefore, as the mandible grows forward, this lower incisor is not getting pushed back because of the coupling. And so it's kind of free to just move forward at the angle that it's at. And so you don't get the natural dental compensation. And so just be careful, make sure that you're keeping an eye on these cases, checking the occlusion as they come in. And if things seem like they're starting to get out of control and the patient's really starting to grow, it may be a reason to switch over to brackets or be more aggressive with the reverse head gear to try to keep the uppers coming forward with the lowers. So let's talk about growth a little bit. And we are fortunate to have Don McGann on here. So I might ask him to chime in just a little bit, because in my mind, he is a world's leading expert on growth and orthodontics. But some basic things to understand with growth. All of our cases, we should have a lateral ceph. And so we should be able to look at, in all of our cases, the cervical maturation, the cervical vertebrae maturation. So we call that CVM, cervical vertebral maturation, okay? And so looking at these, if we blow it up, what we're looking for is at C2, C3, and C4, we're looking at the underside, and we're looking to see if it's curved or flat, because these tell us different stages, okay? And so, and the other thing is we're also looking at the shape. We're looking at whether they're still rectangular or whether they're becoming more square in shape. And then in SmileStream, we have this nice explanation of the different shapes and the different stages, okay? And then we have a nice, we'll show on the next slide, these nice growth curves provided for girls and boys so that we can get an idea of where they are on their growth chart. Okay, so looking at the CVM for this particular patient, in this ceph, we can see that this patient has curved C2, C3, and C4. Okay, so that would at least put them into stage 3. But then if we look at the shape of the vertebra, they're clearly more square. They're as tall as they are wide. Okay, which is going to put them into stage 4 or 5. Okay, this particular patient, when you really look at that shape, you can see falls more into category 5. Okay, where there's not a lot of growth potential at this point. This example right here that's provided in SmileStream is actually more of a stage 2. Okay, it might have a little bit of curvature on that C2, but C3 and C4 are still pretty flat, and these are still more rectangular than they are, they're wider than they are tall. So this particular one would fall somewhere around stage 2 or maybe even stage 1. Okay. looking at the pictures, when you look at these vertebra, you can see that that's, you know, pretty close to a stage 1. There's only just a little hint of some curvature right there. So this patient could be somewhere in this area right there. The best way to tell where a patient is really at, so class 3 cases, growth is really important. And so in class 3 cases, I think it's a good idea, and we recommend that you get a wrist film, a hand film that shows the wrist and the hand bones on all of these patients, so that we can really identify what stage of growth they're in and how much growth potential they still have. So to give you a quick explanation about these images, and if you have a lateral ceph machine, you can take a wrist film, you know, and the patient just holds the hand up rather than having their head in the machine there. So it's easy. You can get instructions on each different machine how to do that. But if you have the potential of taking a lateral ceph, you should have the potential for taking a wrist film. So it says the first thing that we're supposed to look for, so 1 is look for a sesamoid bone, which we'll see on the next slide. But if that's absent, then we go and look for the pisiform bone. Okay, and you can see what it looks like in these 2 images right here. Here it's just starting to develop right in this area, but we don't have a well-developed pisiform bone here. So here it's not formed, and here it's clearly formed. You can see another bone there that's formed and overlaying this other bone. Okay, but in this first example where it's not present, we really just see 1 bone. We don't see another one that's overlaying it like this. Okay, so if the pisiform bone is not present on girls, that's going to put them shy of stage 2 growth, but rapidly approaching stage 2. And on boys, it's going to put them, you know, just past stage 2 growth, but certainly nowhere near stage 3. But it shows you that they're coming up on their potential growth spurt there. The sesamoid bone, that's the first thing that we look for on these wrist films. You can very clearly see that there is no bone present here, but it is definitely present here. Okay, so that's what we look for first, is this present? Because if it is present, we know exactly where we are. Sorry, this is the boys curve right here, but we know exactly where we are. And for the boys, we're right at the beginning of stage 3 growth. We're right up near their peak of their pubertal growth spurt. If we have the sesamoid bone and the pisiform bone present, then the next thing we look for is capping of the proximal phalanx. So we look at the thumb, okay, and we look for is right here. This is the proximal phalanx. We're looking for capping. And in my mind, what that means is, does this fit? Does this little bone right here, does it have a shape that looks like it's fitting around this bone as if it was a cap, like a lid that I could screw on, you know, like the top of a bottle? If I was to uncap a bottle, does it look like it's fitting it like a cap? And here it's rounded on the edges and it's not wide enough to really fit over the other bone. But in this image, you can see that it is wide enough and it has this little lip, almost like it wants to just form a little cap over top of the other bone. And so that's what we call capping. Okay, and so on the boys' growth curve, we can see where we fall. We're falling past, you know, we're well into stage 3 growth at that point, and we can see where that falls for girls. So that's what capping is. And then the last thing that we look for is union of the epiphyseal, I don't even know if I'm pronouncing that right, of the distal phalanx of the middle finger here. So we go way out to the tip of the middle finger and we're looking for fusion right here. Okay, we're looking to see that these 2 bones have completely fused together. So obviously in this picture, there's a gap between those bones, so they're not fused. We're a lot closer in this one, but you can still see a line in between these 2 bones, so they're not fused. When they're fully fused, you won't be able to see a line or a little gap in between those 2 bones, okay? And that basically puts us very near the end of growth when we see that happen. Now, Don McGann has added an additional stage, which he calls 6 or late stage growth for boys who are class 3, because boys, they can have late growth up to age like 18. Okay, so with this one, he's looking at the ulna and the radius and looking for fusion of these bones as well. And you can see here in this image that those bones clearly are not fused. Okay, there's still a gap between those bones. And we know that growth, so all the way up until age 18, essentially, if you see those aren't fused yet, this young man still has potential growth, and we could see that light growth that actually takes them from being a class 1. We finished them up in a nice class 1 occlusion. They've been done with braces or aligners for a couple of years, and now all of a sudden they start becoming class 3 and they have a prominent mandible that looks like they need surgery. So whenever we have stage or class 3 growing patients, we always want to make sure that we talk about and document in our treatment plans and our consent forms that we've considered growth, that we've discussed that surgery could be a possibility if there's late growth, and that despite all the best efforts that we make in doing our orthodontic treatment, they could have late growth that could require additional orthodontic services to get their teeth and their face back into harmony and balance, or it could even require surgery to get them back into balance. So we have to make sure that we're discussing those things so that the patient's aware of that. I think, Don, later on, you had some other, as we get into this particular case, you have some other slides in there about growth. But did you want to make any other comments, Don? I just love that we have you on here. Do you want to make any other comments about growth at this point?
No, you're doing an excellent job of explaining it. And for all of us, I don't know, I haven't heard anything for years about the specialty grinding on the GP, and the reason why they can't do ortho is they didn't know anything about growth. Well, then I did my growth study and everybody shut up. But that doesn't mean in your particular community that there may be somebody trying to
to run you out,
run you out, intimidate you, that sort of thing. So I think all of you need to know at least this, and how to determine if your patient is growing or not, right? And what that might affect your treatment. Now, really, I did a lot of work, of course, in the growth study on documenting differential horizontal growth of the jaws and the teeth movement, and how the teeth compensate. And of course, that's more complicated, but I'm telling you that we're trying to simplify it down there for you too, to where it comes down to a change in your bite. Is there a change in your bite or not? And if there's not going to be a change in your bite, well, go ahead, grow all you want, But in a class 3 case, which is known to be sensitive to growth. And I can't tell you, it was multiple times in my early career when I had an orthodontist tell me, well, you can't treat a class 3 case until they're fully grown, and then you'll do surgery. I'm going, what? So
like a missed opportunity there.
Yeah, but I didn't have the knowledge at that point. Nobody told me to say, no, just factor growth into your diagnosis, right? Well, nobody knows how to factor growth into their diagnosis except we do. So you're seeing something amazing here where you simply just change the lateral ceph to be something, a bite change, basically. They can grow all they want proportionately, but if their bite changes, then we better be aware of it. And they can. I've had some males grow up to 21, 22. I'll never forget one of them. I will never forget one of them. And also during the treatment, I can remember just wearing class 3 elastics, and we'd fix it to class 1. Okay, you can stop your elastics. Comes back, class 3 again, class 3 again, class 3 again. It just drove me crazy. You were just chasing the class 3. Okay, so this case, even though it's mild, it is a growing class 3 case. So you need to understand the protocols just in case a third party may decide they're gonna throw some criticism your way. And if you have followed the protocols in not only showing that you have considered growth, factored it into your diagnosis, but also like discussed somewhere, written down that you mentioned that this could change into like a surgical case because you don't know.
Yep.
But just because you do whatever orthodontics going on doesn't mean that they can't have surgery later. But they're going to try to point the finger at you that you caused the need for surgery. So,
Right.
and that's the
Yep.
worst. So
I appreciate that. Yeah.
so I think it's really important just to say, when you see a skeletal class 3 of significance, this one, I don't remember what this one was, but let's say a width of a -3, everything is going to be widths these days. So get used to that. A width of 0 plus or minus 1 is class 1. A width of a minus number is going to be class 3, like -2, -3, and you get up to -10 or 11. Well, that's a surgery case, okay? That's like 10 millimeters difference between the upper jaw and the lower jaw. And then, of course, the class 2 will be positive numbers. So be sure to learn widths, understand what it is, identify your class 3 cases, follow some protocol, and then go do your work.
Yeah. Thank you, Don. Thanks. Appreciate that. And so just to follow up on that, that's why we take lateral cephs. We can't identify skeletal relationship unless we take the lateral ceph and trace it. And then a reason why on growing class 3 cases, you would want to do an unlimited product, because you don't know how growth is going to affect this. You don't know how long you're going to be working on this case. If I'm doing a growing class 3, I want 5 years and I want unlimited aligners, because I may have to keep, as Don said, it just, you fix it, it comes back, it's got more class 3. You might have to keep going with class 3 elastics. Even though all the teeth are straight, you have to keep going with class 3 elastics, possibly even headgear. You might have to be adding more IPR later. There may be things that need to be done just to keep up with growth, even though the teeth are basically straight. So make sure to use an unlimited product for sure on your growing class 3 patients. So another thing we want to talk about, because we're going to see it in this case, and it's really important for all class 3 cases, is functional shifts. Now, this case, we're going to see 2 functional shifts. We're going to see a lateral, so you can have a left or right functional shift, which we'll see in this case. But we want to check in all class 3 cases, if they have an anterior crossbite when they come in, you want to check to see if they forward functional shift. Okay, what that means is that they are shifting their mandible forward in order to get their teeth together. Because if they put their mandible in centric relationship, where it's most comfortable for the joint, they're going to be hitting edge to edge on the incisors. And that's not a comfortable position to be hitting edge to edge. And because of the skeletal class 3, the discrepancy between the position of the upper and the lower, they cannot bring their jaw back any further to get their lower teeth behind their upper in order to bite down. So to avoid this collision, they shift their mandible forward. They push it forward, and they're functioning in a more forward position in order to avoid that collision on the front teeth and get their teeth together. And so, that happens right from the time that their permanent teeth, their permanent incisors are erupting. It could even happen in the primary dentition. But if they have a forward functional shift, why would we want to know about that? Because it changes our diagnosis and treatment plan. There's a difference between a patient who looks very class 3, like this ceph right here. If we said, hey, here's the mandible, here's B point right here, and here's the maxilla, and here's A point right here. And so where these 2 points line up can look like they're very far from each other. But what if this patient is pushing their jaw into a functioning forward position? We would think that this patient's a very strong skeletal class 3, when in reality, they can actually bring their mandible back far enough to bite edge to edge on the front teeth. Now, all of a sudden, the skeletal discrepancy is not as big. The amount of class 3 in the posterior occlusion is not as big. And so we're treating a more mild case. It just looks more severe because the patient has a forward functional shift. So how do we screen for this? Whenever a patient's coming in for orthodontic records and they have a crossbite in the front, they have an anterior crossbite, when you're taking your photos, you're simply going to say, can you bite so that your incisors are edge to edge, and show them. Put your teeth edge to edge on the front teeth and go, can you bring your mandible back? Can you bring your lower jaw back and bite on the edges of your front teeth? And if they try to do that and they can't, they keep looking like this picture right here, then you know this is their true position. This is really how much class 3 you're dealing with, both skeletal and dental. But if they are able to shift their mandible back a little bit and get to where they're biting edge to edge like this, okay, you will have a posterior open bite when they're in that position because their teeth don't fit together like this because they don't ever bite like this. But it at least shows you that the patient is not as severe a class 3 as they appear to be because they do have a forward functional shift. So anytime you see patients who have an anterior crossbite, you ask the additional question while you're taking records. Can you bite edge to edge on your front teeth? And if they can, please document that position with photos in addition to their full maximum intercuspation. Okay, because that way we know what we're dealing with. Is this a more mild pseudo class 3 with a forward functional shift, or is this a true big skeletal class 3 case, and this is really where their jaw wants to function? Okay, we're going to be talking about class 3 elastics in this case. So just to introduce those, when you ask for button cutouts in your setups with progressive aligners, you'll see the setup come back with this blue line. So in class 3 cases, you want the button cutouts on the lower 3s or the lower canines and the upper 6s or the upper first molars. Okay, and so when the aligner comes, you're going to see that the aligner is trimmed with this cutout in it. Okay, and the lower one's going to be trimmed with this cutout in it. What that means is at some point during treatment, you're going to be bonding buttons onto these teeth. Okay, whether you're using preformed metal buttons or preformed ceramic clear tooth colored buttons, or you're using a composite tool to, which we discussed last time, the mini mold, the ortho mini mold tools that allows you to pack it full of composite and bond it right to the tooth and make your own composite buttons, whatever, maybe you're bonding a bracket, a clear bracket on the tooth, whatever it is that can hold an elastic, you're having to put something on those teeth in order to be able to put a class 3 elastic. So this is a nice picture of what it looks like when a patient's wearing aligners and class 3 elastics and they're having buttons there. Okay, and the idea being that the patient would wear these 22 hours a day, and this is in addition to the aligners. So you have to be able to have a patient who's not only compliant wearing the aligners, but is also compliant in putting the elastics in and wearing those elastics in addition to the aligners in order to get some class 3 change. Okay, now what's going on when you wear these elastics? Well, all of the teeth are basically bound together with plastic. So it's like any movement has to be en masse, all the teeth in that arch moving together. You're not going to get a lot of distalization of the lower arch, even though we're pulling back. Okay, perhaps if you extract lower 8s before you start treatment, it might give you a little bit more distalization of the lower arch, but remember, it's going to be en masse tooth movement. And so you're not going to see a lot of that happening in the lower arch, but what you're going to see more of is you're going to see more of en masse advancement of the whole entire upper dentition. Okay, so as these elastics are pulling forward on the upper 6s, you're going to see en masse, because they're all inside of this aligner, you're going to see some advancement of the upper teeth. And again, if you were to take out lower 8s, you'll maybe see a little bit of distalization or retraction of the lower dentition to help fix the class 3. Now, you might see in certain cases, you might have said, hey, we're going to extract the lower 8s to create some room and to create the cellular activity that allows for rapid bone changing. And we're going to actually use our aligners to sequentially distalize in the lower arch. We're going to move the 7 back 1 millimeter or 2, and we're going to move the 6 back 1 millimeter or 2, and then the 5, and then the 4, and then the 3. And that's actually happening inside of the aligner. And now we're wearing the class 3 elastics, not only to get the en masse movement, but also to reinforce this sequential distalization that we might be doing in the aligner. Okay, because by anchoring the lower 3s to the whole entire upper arch inside of the aligner, you're basically saying that as I push distally on these posterior teeth, I'm preventing the anterior teeth from reacting by moving forward because I've anchored my canines to my whole upper arch. Okay. So class 3 elastics are not only going to create some en masse tooth movement, basically, all the teeth moving inside of the aligner, kind of pulling that whole aligner forward. But also, if you're doing sequential movement inside of the aligner, you're supporting that by creating some anchorage value in the anterior dentition of the lower teeth. Okay, so class 3 elastics are an important part of treating class 3 cases with aligners. A note here from Don, when do we place these? Well, we have to be careful. You can place them as early as, the beginning of treatment, stage 2, stage 3, when the patient's motivated and they want to get a good result. And so you can get started on the elastics right away. Why can't we do that with braces? Well, because when we start out with braces, we have a very flexible nickel titanium round wire in the brackets, which is not going to resist the unwanted movement. So we put an elastic in there with brackets on, and the elastics are going to pull down and forward on this molar and cause it to tip and rotate. And it's going to pull up and back and lingual on the canine and cause it to go out of control. And so we don't put elastics in when we don't have the control until we get into a nice stiff wire, which is the 19 by 25, which takes us, 8-9 months to get to that wire before we can apply the elastics. So with the aligner, because we're not starting off with a real soft, flexible wire, we have, a nice stiff aligner. It's not going to get any stiffer throughout treatment. We can go ahead and start using elastics right away when the patient is very compliant and very motivated. But be careful, because if you have a lot of rotation correction needed on, let's say, the lower canines, and you're pulling with this elastic, you could be within the aligner kind of slamming these two teeth up against each other and inhibiting the rotation correction because you're causing some binding inside of that aligner. So if you are going to use the elastics early and there is a rotation to correct, just check at every appointment with a little diamond strip. Just a fine diamond strip. Make sure that you have nice light contacts between these teeth. And if you're doing a lot of rotation correction, maybe wait until you've got, a lot of or most of that rotation corrected before you start throwing the elastics in, because you could slow down the correction of that rotation. So let me introduce to you Dr. Wiebert Chen. He's in Queensland, Australia. Here's a picture of him in his clinic. Really talented guy. Very smart guy, per Dr. McGann, who works with him. He says, Dr. McGann says he sends him very tough cases when he works with him. So a little bit about Dr. Chen. He started with Progressive Orthodontic Seminars in 2018, 10 years out of university as a general dentist. He thought there was not much more to learn until the first Progressive Orthodontic Seminar, the Intro to Ortho course that he took with Dr. Charlie, one of our well-known instructors down there in Australia, and got excited about this little Intro to Ortho course and ended up signing up for the 48-day traditional orthodontic program, which I highly recommend, and learned how to do full ortho. So orthodontic mechanics at Ortho for Children, did the aligner series in 2019, and took the Advanced Dental Facial Orthodontics program, graduated in 2021. Some quotes from him. He says, Charlie introduced to us the idea of functional shift, which we're going to see in this case, the concept of which was either not taught in the uni or I may have been asleep. And from that made me realize that orthodontics is not just about making pretty straight front teeth, but there's also functional benefits. And so, yeah, absolutely. I presented in, well, I guess it wasn't in my previous presentation, but another webinar that I did, I showed a picture of tires on a car out of alignment. And, if you were to go get new tires put on your car and your wheels are out of alignment, you would see your tires wear down very quickly, irregularly, because you're not functioning properly. So teeth, it's not just about being straight. Yes, we want straight teeth. They look beautiful. It looks cosmetic, but it's about function, and when our teeth are not well aligned, they don't function properly. They'll wear irregularly. The kids, if they're growing, they'll grow asymmetrically, grow irregularly. Teeth will break and wear down in certain patterns because of the way that the teeth are fitting and function together. So the same way that it makes sense for us that a car with new tires should be well aligned so that we get good even wear on those tires, with our teeth, we want to make sure that we have good alignment of our teeth so that as we function, everything is wearing evenly and we're not kind of ruining parts of our dentition by the irregular wear. So function and form, and yes, aesthetics. He said, I feel that completing the Progressive Orthodontic Seminar Series program does not only allow me to perform orthodontic treatment, but gives me more appreciation for the importance of occlusion, which is applicable in many aspects of general dentistry. So thank you to him for providing us with these records and this treatment. And we just wanted to highlight him and also just point out to you that, all of us started off as a general dentist with very little orthodontic training. And thanks to Progressive Orthodontic Seminars, we have learned how to do orthodontics at a high level. The goal is to treat at the level or above the level of the specialty. And for me in my practice, it was life-changing. And the best thing I ever did for my dental career, and making me a better clinician in every regard. And so here's the young man that presents at age 15. I'm missing some questions over here. Let's see. Will software instruct the stages of the bonding of the buttons, or the doc decides when to do the bondings? The staging, so I've seen cases where the stagers will all of a sudden you'll see a button cutout show up. And so they're suggesting that maybe if you hadn't requested elastics, you might see them put elastics on at a certain point. But if we're diagnosing and treatment planning these cases properly, we should be the ones dictating whether or not we want to use class 2 or class 3 elastics and what stage we want to start those.
Yeah, let me just pop in here. I was just answering that when you did it. At the next level, as you get to understand this more, you're going to specify when you want the cutouts made. And so you see, if you make a cutout, then that weakens the aligner right in that spot.
Mm-hmm.
And maybe you're not going to get quite the tooth movement that you wanted. Let's say you had upper or lower, in this case, lower canines that were rotated. You don't want that cutout there right now. You want to first align that teeth and you say, you know what, at stage 20, I want you to make a cutout. Now you see the cutout in the new trays, you say, oh, I got to bond the button. Okay. Now, in my progressive aligners, you can ask for that and you'll get it.
Mm-hmm.
I'm telling you that the other companies I worked with,
They're not
get it. They're not going to do it. They don't have the capability, I think, in the manufacturing. They put a cutout.
It's there the whole time. Yep.
At the beginning of the case, and that's it. And is there for the whole time. And I object to that.
Yeah.
So, and as far as lower distalization, that was the other question there. Lower distalization is not really like predictable. So I personally don't put it into my diagnosis. If you want to distalize the anterior teeth, well, you do it with IPR anterior and posterior, but not counting on the distalization. So I don't know if it's a good idea to be asking for sequential distalization on the lower. I know Amit objects to that like all the time, like don't do it even a half a millimeter.
Well, yeah, I agree. I think in my experience, if it's a young patient and they have lower eights present and we distalize a millimeter and a half, 2 millimeters in the lower arch on a class 3 case, and they wear the class 3 elastics, I've seen good results with that. What I object to for sure is if they're using distalization on a class 1 or a class 2 case as a way of fixing crowding. Absolutely not, because you can't distalize both upper and lower arches at the same time because one's got to be the anchor for the other. But I agree with you too that if you're not seeing the results with the distalization, then the IPR in the lower posterior certainly gives you that same effect.
Okay, now this question was not specific. It just said distalization. You're going to see cases here where we specifically do distalization in the upper arch in class 2 cases, and aligners are the appliance of choice, I believe, because you don't have all this coils and TPAs and all that sort of stuff going on. And so you know, you will see presented here distalization cases in the upper. Okay, and that's something that is different than in the lower. So I'm not objecting to the fact of distalization, just don't expect too much from it.
Yeah. And even when we do the distalization in the upper, you know, you're not going to distillate 6, 7, 8 millimeters, but if you're trying to distalize 2, 3, 4 millimeters, you might be successful with the upper if the patient is good and we have the right patient, you know, they don't have a low sinus and they're not skeletal open. So there are conditions on which we'll get better results than others. And we'll talk about that when we do those cases. So great questions. Thanks, guys. Thanks, Don, for your input. I appreciate it. So here's interesting. The young man comes in age 15 and his chief complaint, he says his lower jaw is shifting to his left and he's concerned he doesn't want it to get worse. And I love that. I mean, how many young men are that astute to come in and not just say, hey, my teeth are crowded, or not even pay any attention, and says, hey, I noticed my jaw is shifting. I mean, he's pointing out a functional shift to you, which, you know, many dentists or orthodontists might never even notice that there was a functional shift here. He's aware of his functional shift, but that should also tell you that he's very astute. So you want to make sure that you are going to be treating this case well, because he's probably going to be very cognizant of what's going on in his mouth. Looking at his images right here, you can see, as you look at the lower part of his face, it does look like his chin is off, and it seems like the lower part of his face is deviating off to his left side a little bit. So we'll look in the mouth and see what signs we might have that, looking at the teeth, you know, and also looking at frontal ceph, that perhaps he has a deviation of his mandible off to his left side. Okay, so what do we see in these records here? Well, the first thing I always look at is, you know, what is the facial profile? Do we have a real convex profile? Do we have a real concave profile? Or do we have a straight profile? Am I happy with the way it looks? Before I ever even look at the teeth, I go, do I want to see his lips move more forward to make his face look better, or move back to make his face look better, or stay about where they are? And when I look at the aesthetic line or aesthetic plane, a straight line, which I can't draw with a mouse, but from his nose to his chin, he's about straight. He's right along that line. His nasolabial angle is a little bit less than 90, so it's a little bit acute, which gives a sense of kind of fullness in his lips. His sublabial fold is pretty average. So when I look at his face, I don't necessarily want those lips to come forward and become more protrusive because of this nasolabial angle and the fact that he's already pretty straight. And I definitely wouldn't really want to see them retracted, because then he would start to have a concave profile, especially if his mandible were to grow more. So I'm looking at his face and saying, I'm pretty happy with his facial balance. I'd like to try to finish with his incisors right around where they start, so that we can maintain his lip support and his facial balance. So that's what I like to look at before I ever look at the teeth, so that as I start getting focused in on the teeth and the bite and all these things, I don't lose track of the fact that I'd like to finish with his incisors near the starting position. So then we look at his face. He has kind of large buccal corridors. You know, his smile would certainly look a little bit better if we expanded him a little bit, but I don't know how much crowding there is in the upper. And if I were to expand too much, that could create some spacing in the upper arch that might retract his teeth and cause things to, you know, move backwards. And I decided I didn't want to do that. So he could maybe benefit from a little bit of expansion if it's going to help our case. His upper midline looks pretty well aligned with his upper lip, but maybe off to his left a little bit. So upper midline might be off to the left a little bit and maybe could be aligned a little bit better, but certainly some asymmetry going on in his overall face, especially when you look at this picture here. You can just see that his chin's off. So when we see that chin off, you have to ask yourself the question, is this a functional shift? Is he shifting his jaw to his left, or is it skeletal asymmetry? You know, is his mandible have a different length ramus on one side versus the other, or is it a combination of the two? We don't know until we start looking more closely at the case. So let's look in the mouth and see what we find. Okay, so we look in his mouth and we see the upper midline. Remember, the upper midline, if anything, was off to the left a little bit. So that means his facial midline would be somewhere around here. And then we see the lower midline way off to the left compared to the upper and compared to the facial midline. So when we look at the midlines, there's definitely a suggestion that he could be functioning with his mandible off to his left side. So what other things would we expect to see if that's the case? Well, we would expect to see an overjet difference in the posterior occlusion from one side versus the other. Okay, so looking, for example, at the canines, if you look at the overjet, does it look like he has more horizontal overjet here compared to here? And in this case, yes, it does. It looks like this is very tight right here. Not necessarily in crossbite, but almost getting close to crossbite. And over here, it looks like we have plenty of, if not maybe even a little bit of excess overjet. So looking at the overjet, it would suggest that, yeah, there may be a functional shift off to his left. Sometimes, especially in class 3 cases where the transverse dimension of the maxilla is deficient, we might even see that we have a full posterior crossbite on the side that he's shifting towards and no posterior crossbite on the other side. And so that would, strongly agree with the fact that we are thinking that maybe he shifts his mandible off to his left side. And in this case, we don't see a full posterior crossbite, but definitely a change in the horizontal overjet back there. Then we look at the frontal ceph, which is a very good idea to take if you suspect any of these, or just take them on all of your cases. But when we trace this frontal ceph and we identify where the midpoint of the mandible is, and we identify where his two front teeth come together compared to his overall facial midline, this also is confirming that there's a functional shift of his mandible off to his left side, because both of these points are shifted off to the left side relative to the overall facial midline. And when we look at the size of the ramus, it looks like those distances are pretty symmetrical. So this is suggesting that there's not a lot of asymmetry in the bone, but there's definitely some shifting of the mandible. So I'd also expect to see, as the mandible shifts off to this side, we haven't looked at his posterior occlusion yet, but if it's shifting to his left, that would bring the lower right posterior teeth into a more forward position, making them, if there's dental class 3, it seems like that would make them more class 3 on the right side, and it would shift these teeth on the left side more posteriorly relative to the upper. And so we might see a little bit less class 3, or maybe a class 1, or a little bit of class 2. So we'd expect to see a difference in the classification one side versus the other. Okay, how do we really know for sure if the patient has a functional shift? Well, we would have to put them in a splint and have them wear that splint full time for several weeks, and then have them come back and see if the shift has gone away, see if his lower midline is now lining up with his upper, because by having him wear a flat plane splint, we're essentially erasing the occlusion and letting the mandible settle into the most comfortable position in the condylar head, settling into the fossa. And so if we see that when that starts to settle in, that now the lower midline is lining up better with the upper, the overjet looks more, equal on both sides, that's confirming to us then that there truly was a functional shift. Okay, and then you would get corrected records. If we skip that step and we just go right into aligners, assuming that we do have a functional shift, which is what we're going to do in this case, we have to anticipate that just wearing the aligners alone is going to help fix that functional shift, because you throw a bunch of plastic on top of all of these teeth, upper and lower, and that plastic between the teeth to some degree acts as a splint. It kind of uncouples the teeth, like we talked about earlier. And when the teeth are more uncoupled 22 hours a day, the mandible is going to tend to want to settle into its more comfortable, normal centric relation position. And so we may see just naturally some shifting away from the functional shift back towards a centric occlusion or a centric relation. Now, in this case, we're going to encourage that by placing buttons on the upper right canine and the lower left canine so that we can wear a cross elastic to help encourage that shift to resolve. Okay, so that may be another elastic that we might want to use in a case that has a functional shift, is a cross elastic in whatever direction will help us to fix that functional shift. Okay, but that means too that we have to, in our setup, somehow communicate to the technician, and hopefully we're working with technicians and stagers who understand what we're talking about, that we have a functional shift and that they're not just aligning all of the teeth and creating centric occlusion where all the teeth interdigitate in a position that is actually not the true home of the mandible. You know, the mandible's in a shifted position. We don't want to make all the teeth line up perfectly in that position. We'd rather let the mandible come into its centric relation and then line the teeth up or make centric occlusion match centric relation. So how do you communicate that to a technician? And we're going to see in the setup how that was done. And we're going to see what that looks like and how the technician is making sure that if we were to shift the mandible back over to the right side a little bit, which we call a hinge rotation, that the teeth are going to fit together in centric occlusion in that corrected position. Okay, so it's a complicated case. Even though it's a mild skeletal class 3, having a functional shift can create a complexity. And if we miss it, if we miss the fact that there's a functional shift, we can be dealing with, again, naturally it's going to want to correct as the patient wears the aligners. We could be dealing with this later and kind of have an occlusion that we didn't necessarily expect. Okay, so this image shows us what's going on with the posterior occlusion. So looking at the molar, you can see that the molar relationship is definitely class 3. Okay, a class 1 would have this distal buccal cusp of this upper first molar more in this position. Okay, so it's not a huge class 3, but it's definitely, you know, a millimeter or two, maybe 2 millimeters of class 3. And then looking at the bicuspids in the canine, it's just slightly class 3, maybe a millimeter. You can see it a little bit more in the photo because the photo is taken from a slightly more mesial position, but you can appreciate that there's, you know, for sure a millimeter or two of class 3 on the right side. And if we go look over the left side, we can also see that that molar is a class 3 relationship. Okay, that distal marginal ridge is occluding further back on the lower 7 than we would want for a class 1 occlusion. And we can also see that there is a little bit more of a class 3 position in the canine on that left side. Okay, so everything points towards the functional shift except for the posterior occlusion. The posterior occlusion is pretty much the same on both sides. And so there may be a little bit of dental asymmetry, kind of compensating for the fact that there's a shift of the mandible. Because normally when there's a shift of the mandible, we would expect to also see a difference in the classification on one side versus the other, which we don't really see in this case. And what else do we see? We see that the bite is tending towards being open. Okay, there's a little tendency to just be open here in the anterior. We don't have a true anterior crossbite, but also the anterior overjet looks a little bit deficient. And so if this patient is still growing, we could be dealing with a collision in the front that's hanging us up from getting our teeth together in the back. So we'll want to, as we've already talked about, since a growing patient, we're going to want to compensate and try to finish with excess anterior overjet to make sure that if there is any growth, he's going to be able to get his teeth together. Okay, here's a nice MEDIT scan, some images from the MEDIT scan. You can see the deficiency in the anterior overjet. You know, definitely right there, we're a little bit deficient. You can see the little tendency towards being open here in the front. Let's count crowding. You know, this case doesn't have an incredible amount of crowding. How much crowding would I estimate in the upper arch? Over here on the upper right side, there's a little bit of, you know, a few little lightly broken contacts. So I might give that 1 over there. And then we have these broken contacts. So I'm going to estimate somewhere around 3 millimeters of crowding in the upper arch. And in the lower arch, again, we're counting broken contacts from mesial of the first molar to mesial first molar. And here we might have a little light broken contact there and just some very slight other broken contacts. So I might say 2 millimeters of lower crowding, 3 millimeters of upper crowding. But we have a transverse deficiency in the upper. You know, you can see how it's kind of tight right through these bicuspids. And you saw that too when you looked at the occlusion from the front. It looks a little bit tight through the bicuspids. So I know I'm going to be expanding those bicuspids out to get them into the proper position in the arch, which kind of creates a little bit of space and eats up any crowding I had here. So I'm not really expecting a lot of advancement of the upper incisors to fix this crowding. And the lower incisors are probably not going to change much in their position at all because there's really not a lot of crowding or spacing down there. You can see that there's a little bit of asymmetry in the shape of the lower arch form. and maybe even in the position of these canines relative to each other. And that may be why, even though we have a functional shift, we kind of see the same occlusion left and right, because if teeth have shifted around a little bit as they've come in and settled into this functional shift that this patient might have. What about key teeth? You know, as we're looking at aligners, we know that it takes about one aligner stage for every degree of rotation. So as I look at like, what's going to be a key tooth here that's going to determine how many aligners it takes to fix this case? Well, this upper right 2 looks like the most rotated tooth of any tooth in the whole case. So probably this is going to be a key tooth that determines how many aligner stages it's going to take to fix this case. You know, we're going to have some bicuspids that need to move out. We're going to move those at about 1/4 of a millimeter per aligner. We have a rotation here on this lower left canine, this lower left 3, that's going to need to be corrected. So that's probably the key tooth in the lower arch, because that looks like the most rotated tooth in the lower arch. There's definitely some rotation on this upper right 1. Okay, so we're kind of looking at these and going, how many aligner stages do we think that's going to take? Well, we're probably up in the 20 to 25 range just by looking at those key teeth. But I'm going to go unlimited on this case because he's a growing class 3, and I don't know how long it's going to take to keep up with his growth. I'm not going to put myself in a place where I don't have more aligners to deal with additional growth. Here we are from a lingual view with this Medit scan. You can see a class 3 relationship in the molar, the way that it occludes with the upper occludes with the lowers. In a class 1 position, this mesial lingual cusp should be right in the central fossa of the lower 6. And you can see that those are shifted more distal. Okay, so there's definitely some class 3 in that molar on both sides. And let's see what it's going to take to level the occlusal plane here. So the occlusal plane is determined by the distal buccal cusp of the lower first molar and the buccal cusp of the lower first bicuspid, so the 6 and the 4. So when you draw a straight line between those 2 points, you can see that these lower incisors are actually underneath the occlusal plane. So even though if I just look at this section right through here, he seems to have a curve of SPE, when you actually take the whole arch into consideration, it's actually a negative curve of SPE. Okay, we actually can create a curve of SPE by extruding these lower incisors up to the occlusal plane and maybe even a little bit beyond it. So since there's a little bit of an open bite tendency in this case, I might want to extrude these lower incisors to help make sure that we're not going to have an open bite at the end of the case or still have that open bite tendency. In the upper arch, the occlusal plane, you can see those incisors are right on that occlusal plane. So we're probably not going to want to intrude or extrude his upper incisors. They look like they're right about where they should be. Okay, so here's some images. They look an awful lot like the scan, so no new information really there. But looking at his, let me go back a couple slides here and show you. Do you see the angulation of these lower 7s? Okay, those lower 7s have distal crown tip, and it may be that the reason why we have a functional shift of the mandible is because of the way that the 7s with this distal crown tip are interacting with the upper teeth, either on the right side or the left side or both. So part of this case to get rid of the functional shift is probably going to be trying to get these 7s aligned properly and get rid of this distal crown tipping. Okay, which means it has mesial root tipping. So there could be an 8 right here that's making it tip that direction. And we may need to extract those 8s in order to get those roots aligned. And so looking at the pano or the OPG, we don't have any upper 8s present, but we do have these lower 8s present. And if I've got mesial crown tipping, and I'm going to want to, we have distal crown tipping, right? We have distal crown tipping. So I'm going to want to tip those roots distally to get the crowns to move more mesially, to align those properly. It's going to make sense to extract those 8s before we start treatment. Okay. So keep that in mind as you look at these cases, that if we're trying to correct tipping of, whoops. So you can see right here, Don, when he set this up, pointed it out to us, that probably the reason for this functional shift is the way that this mesial buccal cusp is occluding with that distal marginal ridge of that lower 7 to the upper 6. And that could be causing things to shift over here. And so in order to get that shift to correct, we would want to get rid of this distal tip that we have that's pushing this mesial cusp up too high. We're going to want to tip that crown mesially, which means that the root has to go distally. So if my root goes distally, it would make sense to get rid of that 8. Okay, so keep that in mind as you set these cases up. So some treatment options that were considered for this young man. Here's what the actual treatment decision option was: non-extraction, which is the preferred treatment on a growing class 3 case, especially if there's a lot of skeletal class 3, because if we were to extract, it would make it very difficult if we later needed to go do surgery to fix the facial balance. So the treatment choice on growing patients is to treat non-extraction. Okay, so non-extraction using some expansion and some IPR in the lower arch and some class 3 elastics to try to get molar class 1. Okay, because he's again pretty mild. He only had like 1 millimeter or 2 of class 3 on each side. We're going to want to overcorrect a little bit, but that's the treatment choice. Okay, we would also want to consider extractions of upper 5s and lower 4s to control the open bite. You know, if we were doing braces tend to open bites. We might consider this more strongly. We'd still probably want to finish with his incisors near start position because his facial balance was good. But remember that aligners tend to deepen bites, brackets tend to open bites. Okay, so we're probably not going to consider this option with aligners because the aligner is going to tend to deepen the bite anyway. And his lips had good position now. We didn't really need to retract him. He wasn't too protrusive. We could extract lower 4s only and finish with a full molar class 3, but we don't have enough distal or differential horizontal growth predicted in him because he's not a strong skeletal class 3 to warrant moving those lower molars into a full 8 millimeter class 3 position when right now they're only like 2 millimeters class 3. And he doesn't really even have an anterior cross bite. So really neither one of these, even though they might have been considered for, being complete, it's not really a strong consideration. And then jaw surgery, we always want to document that we've considered this in growing class 3 patients, but he doesn't stand to gain a lot of improvement to his facial balance by doing jaw surgery. Okay, but if he were to have late growth, as Don said, he's seen patients grow up to age 20, 21. If he were to have an unexpected amount of growth and his facial aesthetics became a problem, we would have to reevaluate for possible jaw surgery. So in SmileStream, which is how we work up these cases, we're tracing the lateral ceph, we're tracing the models, and we're coming up with a 2-dimensional VTO or visual treatment objective to help us understand what's going to happen in the different treatment choices that we are presenting here. Okay, so here Don has traced the lateral ceph, or he and together with Dr. Chen, probably Dr. Chen traced it first, using a medium ovoid arch wire to maintain this arch form. Okay, is coming up with a alignment only basically VTO that shows a little bit of retraction of the upper incisor. Okay, even though we had seen a little bit of crowding in the upper. Where would that come from? Well, that's coming from the fact that the bicuspids are having to move out to this arch wire because they're a little bit deficient. And that's enough to create actually a little space in the upper instead of this crowding that we saw. And so these actually, instead of going forward, might come back a little bit. And in the lower, since there really was no significant crowding, we're seeing those finish right about where they started. Okay, so this would be an alignment only VTO and the potential for a collision here in the front and insufficient amount of anterior overjet. So we'll have to do something to create the overjet that we need. Okay, so here's the extraction of upper 5s, lower 4s. Quite a bit of retraction predicted with moderate anchorage to those upper and lower incisors. So not really beneficial to his facial balance and would tend to deepen his bite. So if we were doing braces, maybe we would consider that and try to maintain the forward position of the incisors, but not really consideration for the aligner case. And then in extraction of the lower 4s, we end up with basically the same VTO as non-extraction because we're gonna have to move those molars all the way forward because we really don't have a big enough class 3 problem to warrant extraction of just the lower 4s. Okay, so here's the VTO of expansion upper and lower expansion using a non-extraction ovoid number 1 arch wire in the dental CAD model tracing. So now you can see that these bicuspids have to move way out to that expanded arch wire. So that's going to create more spacing in the upper arch, which is why we see the upper incisor coming back more than in the previous VTO. And then why are we seeing the lower incisor come back now? Because initially we saw it finishing about where it started. Well, that's because not only are we putting an expanded arch wire in the lower, which obviously we're not using arch wires with our aligners, but this is how we get accurate VTOs is we show with an arch wire that we're going to be moving bicuspids out to expand them. Okay, so if we do expansion of the lower and the upper, and then we're going to add lower IPR. This is 2.5 millimeters of lower IPR. So he's going to have moved some points. You can see that this point right here was moved from its original position, moved 2.5 millimeters back to this position in order to represent that IPR. So now the VTO shows lower incisor being retracted. Okay. And so that's the treatment decision. We're going to do some upper and lower expansion, and we're going to do lower IPR. And then we're going to add class 3 elastics to make sure that we're finishing class 1 and overcorrecting a little bit. Okay, so here Don throws in a little bit of extra information about growth using a growth tool that was available. It's not in SmileStream, but some of you have used it and was available in the previous software that we had available to us. And he's pointing out here that the cervical vertebra show us that, he's pretty much done growing, but looking at him, he has immature facial hair on his lip. He probably still has growth potential left, right? So this is not a software that I used a lot and have a lot of experience with, which is why I like that we have Don here, because he can comment on these slides a little bit. Okay, but he's using this growth prediction software to predict 2 more years of additional growth and adding an additional potential millimeter of growth, differential horizontal growth into the bite. So Don, do you want to make any comments on these 2 slides here while I've got these up?
Sure. Well, first of all, I had him as a bone maturity 4. That'd be that's the growth stage, even though that he was older, right? And so running through the like prediction software untreated, in other words, nothing in there, just just naturally, he was going to have 3 millimeters of additional mandible growth compared to the maxilla. Okay, then the question is, does the bite change from that? And so here in the SmileStream, in the IP soft version, you had to look at where the incisors came in contact with each other at the start versus the end. And so there might be a millimeter there only of change at the incisors. So that's what we're talking about right there. All this other stuff, if that moves forward, if that moves further forward, okay. But as long as our bite doesn't change, but the bite's changing there. And so that's why the 1 millimeter change on the lateral sep.
Right.
So without this tool, today, I would just say, for protocol, add a millimeter.
Yeah.
I mean, a millimeter is not that much, but it shows everybody that you were considering growth, and don't come at me with some pointed finger about my education. And so, and if he doesn't grow that way, he doesn't have a change in his bite, well, then you don't need class 3 elastics. If he does, well, you've already factored it in. Build in some class 3 elastics and just expect it. Now, if he grows more than this, well, you'll need more class 3 elastics. And in the worst case, not the worst case, you need jaw surgery. But
Right.
in the next worst case, you might have to add some reversible headgear, and you'd be fumbling around going, oh my God, look how this case turned out, Why didn't I see this coming? Well, all this says you saw it coming.
Right.
It's just a matter of the magnitude. Okay.
Yeah. Yep. Hang on, I'm open my door. It's getting a little stuffy in here. Now that everybody's gone, it's nice and quiet outside. Thanks for that, Don. I appreciate that. And there's a question here in the chat. It says, how do you relate the amount of IPR with the retraction of the incisors? Is there a formula? You guys will remember that basically IPR is just removing crowding. So we all know that 2 millimeters of crowding equals 1 millimeter of advancement. Okay, so basically your crowding number divided by 2 is the amount of advancement. So if I was to remove 2 millimeters of tooth structure, I would be removing 1 millimeter of advancement. Okay, so 2.5 millimeters of IPR is going to give me a little bit more than a millimeter of extra retraction. Okay, so we're getting retraction here from expansion and from IPR, but that's the formula. Is if I do 6 millimeters, which would be an awful lot, but if I did 6 millimeters of lower IPR, I'd get 3 millimeters of change to how much. So if I had no predicted advancement of the lower, I'd get 3 millimeters of retraction. If I had 3 millimeters of predicted advancement and I did 6 millimeters of IPR, I would expect no advancement. So I hope that makes sense. All right, where were we? We're right here. Okay, so 1 millimeter differential horizontal growth was added to the bite, and just to be safe, and then we had expansion, 2.5 millimeters of IPR lower, and we're coming up with a very acceptable looking VTO that gives us ideal proper anterior overjet and overbite. Okay, so we're going to move forward with this treatment plan: non-extraction, upper and lower expansion. With the aligners, we expand predictably up to 2 millimeters per side. Okay, so we're not going to want to do more than 2 millimeters of per side of expansion. If you need more than that, so say, for example, the upper was more deficient, we had some crossbite, then you're going to need to go in and fix that first with a bonded rapid paddle expander in order to fix the transverse problem before you go into the aligners. The exit plan, we always want to have an exit plan, because what if this young man doesn't wear brackets or he doesn't wear his aligners? We're going to have to pull brackets out and feel comfortable putting those on so we can get his teeth straight, right? Otherwise, we're referring it off to an orthodontist midway saying, hey, I can't finish this case. Can you finish it for me? So Don's got his exit strategy here, putting brackets on, using lingual root torque brackets with an 18 by 25 arch wire. Because the idea being here, if you're going to get out of aligners and get into brackets to finish up the case, you're not going to work your way up into a 19 by 25 wire. More than likely, you're going to finish in an 18 by 25. So it becomes like a one wire technique. You're going to do any additional alignment needed on round niti, and then you're going to put an 18 by 25 in and finish on that wire. And since we're expanding and doing IPR, and the VTO showed retraction of both, then we're looking at the retraction limits. Okay, so we're looking at the retraction limits, this black line of the LI brackets combined with the 18 by 25 arch wire. Okay, and I know we could go into a lot of detail on that, but that's not the point of this particular webinar. Okay, so Don provided a suggestion for the consultation. I have a 18 to 24 month treatment plan to straighten your teeth, fix the class 3. It's going to cost this much. You're going to put down this payment. Okay, so we have a consultation appointment with the patient, present the plan, present how long it's going to take, what's expected, what the fee is going to be. Okay, I'll throw in right here as we get into talking about how was this case treated, because many of you have had this question. Should these aligners, are we doing 1 week aligner changes or 2 week aligner changes? And we touched on this briefly last week, but just because it's a question that's going to come up, I want to just show you what we're doing here. Okay. If your patient, our protocols, if your patient is going to be very compliant at wearing their aligners 22 hours a day, then the recommended time would be 1 week. It's a 1 week wear schedule. Okay. So diligent wearing of the aligner, 22 hours a day, 1 week wear schedule. But are you going to start at 1 week and then punish the patient and make them wear it longer if they're not wearing them 22 hours a day and you're not seeing the movements happen? Or would you rather start at 2 weeks per aligner and know that if you're seeing good tracking and good compliance, that you're going to reward the patient by saying, oh, you're doing a great job. We've been 3 months into treatment. Things look really good. You can now start changing your aligner at 10 days instead of 14 days. And then if I see another month or two of really good progress, I'm going to let you go all the way down to 7 days. And we'll do the rest of the case at 1 week aligner changes. As long as you keep wearing them 22 hours a day, you're doing a great job. And that's up to you. Okay. But what we want you to understand is excellent aligner wear from the patient gives us a 1 week wear schedule. So the recommendation is 1 to 2 weeks, because there's variability from one patient to another. Okay. And the most important one is the patient being compliant and wearing their aligners 22 hours a day. Okay. And other things that will affect that, the age of the patient. Okay? Younger patients' teeth will move more easily through the bone. They're changing, they're growing. The muscle strength of the patient, strong muscle patients, so brachyfacial patients with strong muscles who have a closed bite and skeletal closed bite, their bones are dense, their teeth are going to move more slowly and be more resistant to movement. So they're not going to maybe do as well on a 1 week aligner schedule. Clinical crown sizes, if we have smaller clinical crowns, we have less surface area to push on with our aligners. So those might take longer to get to move into each stage. And then how complex are the movements? How many movements are we staging here? And so there are things that can make it to where a 10-day aligner change or even a 14-day aligner change for that patient may be more predictable, more appropriate. So we're saying 1 to 2 week aligner changes because it really does vary from patient to patient. My recommendation would be start with 2 week. If they're doing a great job, move to 10 days. If they're continue to do a great job, then you go to the 7-day, 1 week wear schedule. And if they're starting to see a tracking problem or not becoming as motivated as treatment goes on, then you back off back to the 10 or 14 days. Okay. The most predictable wear schedule is to ask the patient not to change to the next aligner until all of the teeth fit perfectly into the current aligner and the aligner no longer feels tight. Okay. Because maybe the previous aligner fit great after 7 days. Visually, they could see that all the teeth fit into the aligners. There's no little gaps anywhere. When they bite on the chewy, they don't feel any movement. Okay, everything fits perfect. They don't feel tight anymore. So maybe the previous one, it only took 7 days to get there, but maybe the one that we're wearing right now, for whatever reason, is not quite there at 7 days, and then they would wear it longer. So that would be the absolute most predictable way, is to tell the patient, we don't change to the next aligner until the one that you're in fits perfectly. Okay, so let's look at submission instructions. And I just want to preface this with, we did not have good experiences with previous companies that we worked with as we were teaching aligners to get good setups back. So these instructions being submitted are extensive because this is Don, mentoring this doctor, trying to give him instructions that are going to compensate for all of the things that we see being done weird by other stagers, trying to basically teach him how to do every single movement required. With progressive aligners, we have such talented stagers and designers. We still want to give them instructions. We still want to be the ones diagnosing and treatment planning, but we don't have to be quite as exhaustive in the list of exactly how to do everything. Okay, so I'm going to go briefly through what was submitted for this one. Upper and lower aligners, please synchronize in each phase, meaning that they're, all of the teeth are moving together harmoniously. We don't have to tell the technicians to do that now. Please do not add attachments before stage 3. So if you're going to put your aligners on at stage 3 and you're going to do 2 week wear to start, that means you're going to see your patient back a month after you start treatment. And for some offices, that's how they want to do it. And other offices may want to start it at the attachments on the very first stage, okay, which is the default. So if you like them at stage 3, you're going to need to instruct them that you want to do it at aligner number 3. And some people like starting their patients off with aligners that go on and off easily, that don't have any complication of attachments, just give them a nice, easy start. But then some other people feel like if they give these patients aligners that are nice and smooth with no bumps on them, that they get used to those, and then they're not as happy when they get the ones that have the bumps in them for the attachments. So you decide what works best for you in your practice. Please do not do IPR till the expansion is done and the interproximal contacts have been separated by at least 0.2 millimeters. The point here being, you don't want to do IPR when the teeth are overlapped, okay? I like to ask for them not to apply the IPR to any contact until that contact is aligned properly, okay? I want to do the IPR when the true contact is aligned, so we're taking away the right part of the tooth. Before any rotation movements or intrusion or extrusion, please be sure that there's space. Okay, space is the collisions are the biggest thing that keep the teeth from moving besides the patient not wearing their aligners. So he's asking, please make sure the teeth aren't colliding in the digital setup. Okay, before you start rotating teeth or intruding or extruding, all these things require space. Make sure that there's a little visible space between these teeth so that they're not colliding inside of the aligner, and that collision will cause the teeth to just bind and they'll stop moving. Okay, and that's another reason why in every case I recommend that you use a fine diamond coated metal interproximal strip just to lighten the contacts in between the teeth. Keep them all nice and light so the teeth aren't binding. Okay. He said attachments need to have a gingival bevel. Again, you need to point these things out. We have these things all set up for you. Tooth rotations are more than 2 degrees per aligner. Overcorrect the rotations by 2 degrees. Crown torque, no more than 2 degrees per tray. Doctor will create cutouts. All of this stuff today would be, we wouldn't even need to submit any of that because all of this should be dialed in with our current aligners and with our stagers, unless you wanted to have them do stage 3 attachments because it's default at stage 1. Okay, but here's some things we need to do. Expand. Okay, now I do need to tell them I've decided in my treatment decision that I want expansion. So this makes sense to tell the stager, oh yeah, I want to expand. It says expand buccally, primary in the premolar region. Okay, my premolars were a little bit constricted in the upper, so I want to see those premolars come out. I want to see that arch form rounded out. I want to see it idealized. So this is a great instruction to give the stager. Okay, this is me being a doctor making a treatment decision. I want to tell the stager how I'm deciding to treat the case. Okay, I don't have to tell them how fast to move the teeth. That should be something that we have all dialed in for you. Okay, and we're limited to 2 millimeters per side because that's what's predictable. And we want them synchronized left and right sides at the same time, but that should be done by our stagers. Okay, and he's saying, I want to flatten the curve of SPE with some canine intrusion and then probably some lower incisor extrusion. Remember, we saw that on the lower, we had a little bit of a reverse curve. This says move the upper midline to the right by 1 millimeter. Remember, the upper midline was off a little bit to the left. So we want to move that a little bit to the right to get it centered. He's asking for IPR on the lower arch. Why? Because we made that treatment decision. Looking at our VTOs, we said to treat this case, we're going to need some lower IPR. Okay, so we can tell them, please add IPR to the lower arch. You can even say, I want 2.5 millimeters of IPR on the lower arch. You can even say, I want the IPR between these teeth. Okay, so you can dictate those things. He's asking for a unilateral class 2 elastic jump to correct the mandibular functional shift, centering the lower midline to the corrected upper midline. So the technician should understand, I want the upper midline to go to the right by 1 millimeter because it's off to the left. And then I want the lower, you can either say a unilateral class 2 elastic jump, or you can say a hinge rotation. But what we're telling the technician is, I want you to shift one side only, okay, so that the lower midline lines up with the corrected upper. Okay, because we're trying to correct a functional shift. The patient's shifting the mandible to the left. We want to shift it back to the right and make sure that the teeth are fitting. Now, the aligners are doing nothing to shift it back, okay? But we want the setup to show it shifting back to make sure that the teeth are going to fit together properly when it does shift back, because we're going to put aligners in the mouth, which is going to encourage it to shift back by uncoupling. And we may have them wear cross elastics in the front to encourage that shift to correct as well. And remember, that was a chief complaint for this patient. So we really want to make sure it's part of the setup. Okay. And then here are some things that I don't feel like you probably need to specify because this should all be done by our stagers who are well-trained. But here he said, you know, here's the phases. I want the first 2 sets to have no attachments. Just start to align the upper and lower arches with some simple tipping, create 0 collisions, start to open up my contact. So anytime you start to tip the crowns of the teeth out to the buccal, the facial, it starts to open up little spaces between the teeth, which is perfect because that sets us up for the next phase, which is when the attachments go on in this case, and we start to do these primary movements of rotation. Where did you have that in here? I saw it somewhere. Of rotation, intrusions, extrusions. Okay. Phase 3, start to put the IPR on the lower arch. Phase 4, mesial root torque of upper canines and buccal root torque of upper laterals. Okay, when we do expand in the upper, we want to add buccal root torque to the upper posterior teeth, because as we move them out to the buccal, they're going to tend to want to tip buccally, and that would let the palatal cusp drop down. So we want to ask for buccal root torque as those move out. It says class 3 elastics on both sides, and then virtual chain in the lower arch to close any residual spaces. Okay, this is definitely something that you can request. What is virtual chain? Virtual chain is overcorrective aligners meant to close any residual spaces that didn't close that you had IPR. You know, you did IPR, and you don't have to ask for these necessarily on the first setup. You can ask for them if you have unlimited aligners, but you might not end up using them because you might get towards the end of your first set of aligners and go, you know, this is not a hole-in-one case. I am going to need a revision, which is the most common thing. I will get some additional aligners to finish up the case. So when I get additional aligners, revisions, refinements, that's when I'm usually asking for the virtual chain or the overcorrective space closing aligners. Okay, they know what you're talking about if you ask for virtual chain aligners. They're basically just aligners that say, hey, if there were any little spaces between the teeth, none of the teeth are going to move. There's no alignment happening. All we're doing is just moving all the teeth a little bit closer together to close up any light contacts or residual spaces. It's kind of like when we do braces, and if we want to tighten up the contacts, we would put chain from molar to molar, from 6 to 6, just to tighten everything up. That's what these virtual chain aligners are doing at the end, is just tightening all the interproximal contacts up. Okay, so he goes on further here. After the posterior buccal segment expansion is complete, premolars and molars will need 10 degrees of buccal root torque. That's what I was mentioning a minute ago, adding buccal root torque as we expand the teeth. Again, you don't need to ask for these things now. These are all part of our protocols, because this is just things that when you do this, you should do this to make it come out well. What you need to include to your technicians now are things that are specific to this case, right? Like, I want to expand. I want lower IPR. I want this functional shift. I want this shift of the mandible. These are the things that are specific to this case. The other things we've already designated to our stagers as to how we want the teeth to move. That would be universal to all the cases that have teeth moving that way. Okay, so you don't have to say, hey, I'm going to intrude. Don't go any faster than this amount right here. Those are the things that we now have set up for you. Class 3 elastics bilaterally with a unilateral jump as needed to synchronize the lower midline to the upper. Okay, this is again saying, I want you to shift the mandible so that the lower and the upper midline line up. I don't want you to shift all the teeth. I just want the mandible to shift. I want the whole arch to shift over, okay? And it's not something that the actual aligners are doing. It's a final position in the setup to make sure that if I do successfully get his shift to go away, I want to see how the teeth fit together in that corrected position, okay? So it's a hinge rotation of the mandible, or it's a unilateral shift of the mandible, okay, to get that to line up properly. And again, we're working with stagers here who understand what we're talking about, fortunately. So they'll get what you're saying here. Okay, he says upper lateral incisors need 10 degrees of buccal root torque. Add 10 degrees of buccal root torque to the lower left lateral incisor. We're getting really specific now. Okay, and some of these things are, you don't have to necessarily specify all these things. If you see the setup come back and you don't like the way that the teeth are set up, you can start to get very specific. But Don is the master of seeing every detail and specifying to the technician exactly what he wants on every single tooth. Okay, and I really respect that. Gave the endpoint parameters. Okay, I want overjet of 2 to 3 millimeters. Why? Because I want that extra bit of overcorrection for the fact this is still a growing patient. I want an ideal amount of overbite, which is 2 millimeters. So normally our overjet should be 2 millimeters and our overbite should be 2 millimeters. So he's telling this technician, I want ideal overbite, I want ideal overjet, but I want a little bit of more, little excess overjet. I'd like molars class 1, canines class 1, could have even said, I want a millimeter of dental class 2 to compensate for the growth. Okay, but again, this patient did not have a strong skeletal component and not as much growth left as if he was in an earlier growth stage. He's asking for a mild curve of SPE to be created, where right now that was kind of negative or reverse. He wants all contact points to have marginal ridges leveled and midlines synchronized. Okay, so this was all submitted. These are just what it basically shows you once you've answered all the questions and go into the portal and answer all the questions.
Let me just,
Want to jump in there?
jump in here for a minute. This is painful to watch all this because I know how long it took to figure that out.
Oh
you
yeah,
know?
it's
But now,
hours of work right there, Don.
but now we've got everything all set. So really all you have to say here, you should tell them that you have a hinge axis problem, that you have a functional shift, because you sure don't want them moving all the teeth to one side, trying to get the midlines to center.
Yep.
And so you should tell them that. You should identify which tooth you think might be causing those, in this case, that lower left,
7.
second molar.
Yeah.
You just tell them, I want to level and align everything with overbite and overjet of 2, 3, or 2 in this case, but be sure that you specify just overbite and overjet, and that you are going to expand and do IPR. And then basically the bite and everything comes down to, hey, I'm going to start with this overbite, overjet, and also you do have to give them a starting point, the upper midline. So either the midline is on center, I'll say it, or move the midline in this case to the right 1 millimeter.
Right.
And then everything else gets synchronized to that point. So they have a starting point, and then let them go to work, because these guys are really good. I mean, this is painful because we were so used at that point to be working with another company that if you didn't say it, well, and then and then the more you said, the more they just put it in a round file and did what they wanted,
Yeah.
So, yeah, it was really
It was painful. Looking back, just
Yeah.
really grateful that we are partnered up with such a talented group of stagers.
incredible.
Yeah.
Okay.
Absolutely.
Anyway,
Good comment. Thanks, Don.
Anyway, you're doing a great job, but it's
Yeah.
just
It is painful to look at, isn't it?
it's painful, all this stuff, but you could probably go a little faster because you're going to be here getting home late if you don't. So.
Okay, I'm going to go quickly through these next ones. These are still pictures, screen grabs that Don took of the attachments that were used in the case. And I'm going to actually show you the setup in just a minute with a screen record of the video that me looking at it. Okay, but just highlighting, they're going to use vertical attachments where you have rotations. They're going to use horizontal attachments where you have extrusions. They're going to use horizontal attachments where they need anchor points for intrusions. Okay, so these are all taken care of by the technician. Okay, so here was the first setup that came back, the endpoints. You can see this nice rounded out arch form from the expansion, especially in the bicuspid region. Okay, you can see the features with the button cutouts, okay, as requested. You can see that there's a little bit of IPR added in the upper, which we didn't ask for. We actually asked for IPR on the lower. So in a class 3 case, we're usually not going to want to remove tooth structure in the upper because that's where we need tooth structure. So that's where you might go back and go, okay, well, I did not want IPR in the upper. Please remove that. And why aren't we adding IPR to the lower? Well, we'll see when I show you that actually once they get this in here and measure the Bolton tooth size relationship, there's actually quite a excess in the upper. So in this case, we actually might not end up needing as much IPR on the lower as we thought we would, because we actually do have a discrepancy in tooth size, tooth mass, upper versus lower. And we'll show that in a minute. Okay, and I'll also show you the hinge axis shift of the mandible, but you can see in the photo here that we went from upper midline and lower midline being way off to this like virtual jump where they lined them up. And I'll show that to you in the actual video. But we're saying, hey, this is what we think we're going to end up with as far as the jaw shifting back. So we want to make sure that the teeth line up in this position, not in this position. And I'll show that to you in a second here. Okay, here's some pictures of the super in position to say, hey, I know when I first looked at this case, I did not really want to change his incisor position. So did I significantly change his incisor position? Well, we knew that by doing some expansion in the upper, that we would bring those incisors back a little bit. And, there's 1.5 millimeters, maybe even 2 millimeters of retraction of those upper incisors, but that's not going to be enough to drastically change this young man's profile. And in the lower, one of the incisors basically finished where it started, and the others came back a little bit because of the expansion in IPR. So this seems to be matching what we were anticipating with our VTO. And I'll show that to you again in a minute in a video. Okay, and Don makes a point here that, and you know, I actually tested it, Don. It looks like we don't have a limitation to the number of characters anymore when we submit it. Maybe you can let me know if you still run into that, but we shouldn't be having to submit narratives anymore that are, you know, small novels. And so I don't think we're going to run into a problem with that. Okay, so this is the setup that was approved. There were some changes made to the setup. Again, there was some IPR in the upper. And as we'll see in a minute, that's probably because we actually do, to get these arches to coordinate, we actually do have like 4 millimeters of a bolt and tooth size discrepancy. So there's a lot more tooth mass in the upper. The tooth shapes and sizes in the upper are bigger than the lower. And so to coordinate it, they actually end up having to do IPR in the upper instead of the lower. Okay, so we'll show that in just a second here with some videos. And I'll show this functional shift here in a second with the video as well. But what he's highlighting here is they're showing you a final aligner stage with a J on it that's showing a jump. What they're saying is this is the active aligners up to here. This is what's actually happening in the aligners, but we're going to show you one final position that's just a simulated virtual position where we've shifted the mandible, and just so that you can make sure that we've aligned the teeth properly to fit in that position. Okay, so this is what it looks like in the setup. We'll show you in a minute, is they give you this final jump into the correct position of the mandible. Because the aligners aren't doing that. It's just, you know, the fact that the patient's wearing the aligners and we're going to put some cross arch elastics on. Okay, so the anticipated elastics would be class 3 elastics from lower canines to upper molars, and also a cross arch elastic from the upper right 3 to the lower left 3 to help with this functional shift correction. Okay, that's how we're treating it. It's not anything that's happening inside of the aligner. Okay, so here you can see the staging. These are the active aligners. This tells you when attachments are going on. This is tell you when they're coming off. So here's some attachments going on, different teeth at various stages. They're all being removed at the end. This is where IPR is being done. These little blue diamond shaped things here. And then they're showing you that at the end, there's this occlusal jump, this virtual jump into a new position of the mandible. So let's see what that all translates into. Oh, and then here's our key tooth. Remember, the upper right 2 was the most rotated one. And so we're seeing the number of aligners that it's taking to get that particular tooth completely rotated. It's the one dictating how many aligners it's going to take. And you can see here, 21.3 degrees of rotation needed. So, you know, that puts us up into the 25, 26 aligner stages to get that fixed. And key tooth in the lower, this lower left canine that was rotated, looks like that one's 18.3 degrees of rotation needed. So again, putting us up over 20 aligner stages. Okay, so let's look at, this is how I would evaluate the setup. Okay, I've just got a screen recording of me evaluating the setup. So let me play that for you. Okay, I like to look at it from the front first. I like to come down and grab the slider, and I like to move it back and forth faster than what I get if I just hit the play button. Because when I start to slide it back and forward, and I go back and forth a little bit faster. See, at the end, I'm playing around with this last position, and they're going, oh, see this jump? Okay, you saw that jump happening? They're saying, hey, when we line the teeth up, you see the expansion, you see that little shift of the upper, and then they're like, here's the very last stage, which is not an actual aligner stage. It's just us showing you what it's going to fit together like if we do this little hinge rotation. So let me go back and show that one more time. Okay, so see this hinge rotation? See, so the hinge point is over on the left side, and they're shifting the right side backward to get that lower midline to line up. Nothing is happening in the aligners to do this. They're just going, if you're successful and the patient's wearing the cross arch elastic and there truly is a shift and you're successful in getting that corrected, then this is how the teeth will fit together if that happens, because you asked me to show that to you, right? The technician's saying. So watch in the aligner, watch the upper midline. You can see that the upper midline does shift right here. You can see it shifting. Okay, so the actual aligner is helping us shift that upper midline. And that's another reason why we probably need that IPR on the upper right side, is because how else am I going to shift that midline to the upper right if I don't create some space up there? Okay, so the aligner is shifting the upper midline, the 1 millimeter. But the aligner is not shifting the lower midline. It's just it's just giving us a last final stage to visualize the shift going away if in fact clinically it does go away. Okay. And that's the purpose of that little jump at the end, is just to let us visualize that final position. I hope that makes sense. Okay, so then how else do I analyze it? Then I start looking from the different angles. So I'll go and look at just the upper and slide back and forth, and I'll see the rotation correction, make sure there's an attachment on that tooth. I'll see that there's expansion happening, and that there's some buccal torque being added, some labial root torque being added. So you can kind of see how the gum looks like it's pushing out. So there's extra expansion on the roots to compensate. I can see, when the IPR is being applied because it gets highlighted. Okay, then I go look at the lower. And I can see the expansion happening. I can see that down here on the lower left side, it actually creates some space, and then they're using that space to actually mesialize. Let me pause it here really quick. In the lower, there's some space created right down here on the lower left, and then they're closing that space by actually shifting almost in a sequential pattern. They're shifting the lower posterior teeth forward. So I'm going to want to look on that side and go, in a class 3 case, normally I wouldn't want to advance the lower posterior teeth because that makes class 3 worse. So when I see that, I'm going to want to make sure that that's not causing a problem with my posterior occlusion, right? It may just be what's needed just to get everything into class 1 with the jump. Remember how we're putting a jump at the end? Now, where does the jump come in at the end? Right here. So this is not an actual aligner. It's just showing you, hey, if you do the jump, this is what it ends up looking like. Looking down on the occlusal view of the lower, okay? So then I would look at, just showing you one more time there. So going back and forth, you can look at the attachments, you can look at how everything's moving. Now I'm going to look at the posterior occlusion and see what's actually happening. You can see the alignment of the posterior teeth. There's the shift at the end. There's that functional shift. They go, well, if you correct the functional shift and we line up the midlines, you're going to see that you actually, maybe we still have a little bit of class 3 on that side. But I'm wearing class 3 elastic, so maybe that'll help. And maybe I'll get advancement of the upper and we'll actually get a class 1 on that side. But as it stands, oh, no, let me go back. They're showing that you're going to end up a little bit class 3, but then with the little jump at the end, it looks like it's class 1. The canine is actually a little bit class 2. How can the canine be a little bit class 2 if the molar is class 1 back there? Well, we have a Bolton 2 size discrepancy in the upper. That's why it's not coordinating perfectly. Guys, let's look at the left side, because remember on the left I was concerned because they were moving the lower teeth forward, which would make class 3 worse. See the lower teeth moving forward? But with the jump, all that's doing is just coordinate it into class 1. There's the jump happening. Okay, so this is how I'm evaluating the setups, is I'm just taking that slider, I'm looking from all the different angles and just sliding back and forth, and things jump out to your eye as you start sliding back and forth. From the lingual view, you can notice how the buccal root torque is being added to the upper posterior teeth. See how it looks like the roots are getting pushed out to the buccal? Okay, that's to compensate for the tendency for those to want to flare or tip buccally when you expand them. And then there's that little shift at the end. Okay, so this is a very interesting setup, and you can't get technicians with other aligner companies to do a setup like that for you with that functional shift at the end. It's very difficult or impossible. I like to look at the overjet view. And in this view, you can see how we're anticipating some excess anterior overjet, which is good because this is a growing class 3 patient. And there's no IPR even added in this case to the lower. So if I'm off, as we get to the end of the case, I can always add IPR in the lower arch to give me more anterior overjet if needed. And there's that little shift in that final position. Okay, so that's what I'm looking at. See that little shift. So let's show you what it looks like when we evaluate it with the superimposition tool turned on. To turn that on, you go over and click superimposition right here. And this also helps you to evaluate the setup. So click superimposition, and then, just quickly go back through the same views. You'll see that upper midline shifting. See how in the lower, everything shifts, like the superimposition goes with it? That's because the aligners are not actually doing anything for that. That's just them showing you a final shifted position. But what's actually changing inside the aligners is displayed by this superimposition tool. The start position is the dark, and then the final position is where you see the teeth. So you can see the expansion, but you can see that the upper incisors are finishing near start position, which is what we wanted to maintain its profile. You can see the expansion. You can see the lower incisors are finishing again near start position, which is what we wanted for his profile. Okay, so for some people really like to look at that superimposition tool. It helps them visualize things. You can look at the left and right views and say, what's actually happening here. Whatever you see, whatever changes you see when the superimposition tool is on is what's happening inside of the aligner, what actual movements are programmed into the aligner. Okay, and then one other tool that's helpful. Oh, I jumped over on the last slide, but I want to just show you, you do have an occlusion tool. Okay, so when you hit contacts over here, it does show you your starting contacts and your finishing contacts. So you see all the little green marks. There's not very many contacts here in this case. And then you can see at the end with the shift, they've only got contacts on basically the upper left side. On a case like this, where I'm anticipating a shift, I'm not too worried about what the occlusion is showing right now, because I know that I'm going to be using another set of aligners to refine the setup. To refine the case when I actually get things corrected in the final position. So I'm anticipating really spending time dialing in the bite using this occlusion tool, making sure I like the final bite when I get to the end of the case. And I don't really expect to get that to happen on this first one, where we're just kind of guessing at this functional shift being corrected. Okay, so in this particular video, I'm showing you using some doctor edit tools, okay? Because here I'm thinking that maybe you might feel that there's a little bit too much embrasure space between the upper laterals and the centrals because of a little bit of a tapered shape to those teeth. So if I wanted to reduce that, I could either communicate that to the technician and say, hey, give me a little bit of mesial crown tip on my upper laterals to reduce the embrasure space on the incisal. Or I can actually go into a doctor edit tool and click on that tooth, and I can make the changes myself to communicate with the technician. Okay, so I can change the crown angulation, give it some mesial crown tip. So get to the right tool. There we go. Now we're on the right tool. Now I can add mesial crown tip. You can see that crown tip coming in. And that's going to open up some space on the distal because I just tipped it to the mesial. So now I can go and bodily reposition it more distally to make sure it's in the correct spot in that space. But now it ends up with a little bit less of an embrasure space right there. And I'm only showing you this just so that you realize that there is the potential to go in and use 3D edit, doctor edit tools. If you've been used to using those with other companies, we have some really nice 3D edit tools. And this is just another way of communicating with the technician, because once you're done editing it, you basically resubmit it, and then the technician will go and basically incorporate the changes that you made so that the new setup has those changes incorporated. So you can see here that I'm adding that mesial root tip or the mesial crown tip and then reposition it distal buccally into that space. Okay, so let's look at how it treated out. Yeah, I'm coming up on my 2 hour. I thought he'd be somewhere between 2 and 2.5 hours. So I got to speed it up a little bit here, don't I? So these were shipped out on in August, it looks like. And here are the start positions. And here where we got after 4 months of treatment at stage number 10, aligner number 10. And interesting to me, you can definitely see that there's some straightening of the teeth happening. His teeth didn't look horribly crowded in the first place. If you look at his buccal corridors, you can see that there's definitely been some expansion because his teeth look like I can see more of his bicuspids here. But look at his lower midline. His lower midline is actually now lining up with his upper. Is that because the aligners did anything? No, it's because as we have the aligners in the mouth, it's uncoupling the teeth. His jaw naturally wants to go back to its most comfortable position because he's now basically erasing the occlusion. And we may have had him, I don't know, wearing cross elastics at this point to encourage that shift. But it's interesting to note that the functional shift is already gone or going away at this point. Okay, so here's some photos comparing what we're seeing clinically with what we expected to see by looking at the setup at aligner number 10. Okay, so we didn't expect to see the lower midline aligned to the upper because remember, they didn't apply that jump until the very last stage. But in clinically, I would expect to see either all or some of that being corrected. So you can see that he's had a huge change to that lower midline shifting over to the upper because the teeth are uncoupled all day long. 22 hours a day, he's wearing these aligners and the teeth are uncoupled. So the jaw is going to where it's happiest, to where it functions best. And then when we take the aligners out and have him bite down, I doubt that the back teeth fit together well at this point, but the midlines want to line up because his jaw is getting used to functioning in centric relation. Okay. So here's what we're seeing in the posterior occlusion. See how the back teeth aren't fitting together very well? Like this is what we were expecting to see at this stage. And this is what we're actually seeing. Did the aligners do that? No, the aligners did nothing to cause that. We're just straightening the teeth inside of the aligners. Well, how did this happen? This happened because the patient is now shifting his mandible. Well, he's not shifting his mandible. You know, the shift has gone away. And so now the occlusion doesn't fit together well because it's a whole new occlusion, right? And we tried to set it up in a way that by the end of the case, the teeth would fit together better in this position, which is why they were simulating that jump. But the patient did it within 4 months just by wearing these aligners full time. Question here, you are shifting the lower with the help of the anterior cross elastics, not the aligner. Correct, nothing is happening with the aligner. Okay, so the movements programmed inside of the aligner are doing nothing to make this change. This change is happening either one, because the patient's wearing the cross elastics to make their jaw go the other direction, and or just the fact that the patient's wearing aligners 22 hours a day is similar to wearing a splint. It uncouples the occlusion, okay? And so the jaw tends to go away from the functional shift just by virtue of the fact that the aligners are in the mouth 22 hours a day. Okay, so here's what we expected to see as far as alignment at aligner number 10. And we can see in the mouth that actually it looks, you know, pretty similar to what we would have expected. Maybe that upper right lateral is lagging a little bit behind. Okay, but generally things look like they're tracking pretty well. So if I saw that lagging behind, I would want to go in there with a little interproximal strip, make sure that that contact is very light or that there's no contact at all so that there's no binding. And then I'd want to stay in the current aligner and keep wearing it and use a chewy until I get that tooth exactly on track and it looks like it's fitting perfect in the aligner before I just keep pressing forward. Because the further we go into the aligner series, the more off track the tooth gets, the worse it's going to track because it no longer has good contact with the aligner. We need intimate contact between the tooth and the aligner to get the continued movement, the continued force being applied. Okay, here's the MEDIT scan. Okay, so it's useful to be able to look at these progress scans or these progress photos and compare it to what the setup showed that we should have at this point. Now there's additional attachments programmed to go on. So those additional attachments go on. McGann's comment here at tray 10, he says, each dental arch looks similar to the staging. So good job to everyone. It's looking good. He says, please go ahead and start the class 3 elastics now. So go ahead and bond buttons. If you go back and look, you can see we don't have any buttons bonded. So at this point, you know that there's been no cross arch elastics because there are no buttons bonded on these teeth yet. So no elastics have been employed at this point. The only reason why the patient's midline is shifted and lower is because the patient is wearing aligners and that separation uncouples the bite. And so he's naturally shifted his mandible back or gotten rid of the shift because there's no more teeth coupling. If we were to take the aligners out now and not wear them anymore, his shift would come back as he starts to recouple his occlusion. Okay, so start wearing the elastics. Going to be wearing 4-ounce, 5/16 inch elastics. Thank you for adding the additional attachments now at stage 9. keep an eye on the fact that there's IPR coming up on stage 15 and give me a mentor check at stage 20 to 25 with some new photos. Okay. So he gets some new photos back at tray or aligner number 20. Now we're 9 months into treatment. And you can see that the lower midline is still lining up with his upper. Okay. It looks like when he smiles, it's like his face is trying to get used to this new position that his jaw wants to be functioning in. Teeth are looking straight. Expansions there. Here's how the elastics are being worn. See the class 3 elastics. Okay, so there's the buttons attached, upper molars, upper first molars, lower canines. And these elastics should be worn 22 hours a day, just like the aligners. Okay. And then why are we not wearing the cross arch elastic? Well, because we don't need it at this point. He's done a great job of getting rid of that functional shift just by nature of the fact that he has the aligners in. And now we're applying a balanced force, the same force on left and right sides, which should continue to hold that jaw into the corrected position because we have symmetrical forces being applied. Okay, scan number 20. Shifting back just a little bit as the teeth are starting to come into better occlusion. Okay, so you can see that the lower midline is shifted back off just a little bit. And my guess is going to be that this is actually a little bit more where that mandible is most comfortable. It's kind of found a home now at this point. And remember, the aligners were shifting the upper midline off to the right side because of the fact that the upper midline started off a little bit to his left. So we're going to see that the case actually finishes a little bit with the lower midline off to the patient's left, which doesn't bother me at all. I don't need those upper and lower dental midlines to be exactly coincident. So McGann's comments at this point, please encourage your patient to wear the class 3 elastics through the remaining 8 trays of the series. Tray number 27, please take some new records, including lateral ceph, photos, panoramic, a new scan. We'll either declare the case finished or make a revision and refinement. Okay, so I would anticipate in this case, we've done a lot of work. We were kind of guessing at the bite at the end with that little shift at the end. So we don't really know where it's all going to end up. I don't expect this to be a hole-in-one. This to me is a par 3 or par 4. We're going to need some additional refinements to get everything to fit together. That's what I would have been anticipating. Okay. But either the patient was getting it done or the doctor was getting done. Probably the patient was very happy and the parents were very happy and just decided after 17 months and the first set of aligners, 28 aligners, that we were done. No more additional aligners, no more additional refinements. We're happy. Let's be done. And even though we can be critical about the posterior occlusion not being perfectly settled, midlines not being perfectly lined up, I'm completely thrilled with the result, as I'm sure the patient is. And, this is a beautiful outcome. And to say that you did this in one set of aligners with no revision and no refinements, it's beautiful. There's definitely things that could be improved upon, but this is when they decided to finish the case and it's a beautiful outcome. Okay, so teeth are straight. I know from experience that as this patient goes into retention, initially they'll be wearing the retainers full time. So I wouldn't expect any additional settling of the posterior occlusion because you continue to have plastic between the teeth 22 hours a day. But as we start getting away from wearing the retainers during the daytime and they start being worn only at night, now you have the patient functioning, swallowing, having the aligners or the retainers out during the daytime. And now we start to see coupling of the posterior teeth. So this little bit that I see here, I'm not too worried about because I know that as the patient goes deeper into retention and starts wearing the retainers just at night and during the day they're out, these teeth naturally will start to settle and you'll start to see a nice coupling of the occlusion. So here's the final MEDIT scan. Okay, you can see there's still a little bit of class 3 in the molar relationship on the right side. I can still see that distal crown tip of the lower second molar. So I don't know if the 8s were actually extracted, because that's something if we said, hey, if the patient was willing to continue wearing aligners, what could we improve upon? Well, we could probably continue to try to intrude this mesial buccal cusp or the mesial half of this tooth by tipping those roots distal. We might continue to try to extrude the upper 7, but I know that eventually will extrude down into occlusion. even with the patient wearing the retainers at night, you'll still see that come down and end up in occlusion. The rotation on this kind of key tooth, that upper right lateral, was not fully corrected. Okay, so if we were to be picky, and Don even said here, I wish I would have, not been a softie and said, yeah, go ahead and finish the case, and would have said, nope, you got work to do still. Tell your patient they're not done yet, even though they want to be done. You certainly could have corrected and maybe even slightly overcorrected that rotation. So if there was any relapse, it would relapse towards being straight rather than being uncorrected. Okay, so definitely some work. If we were doing a revision right now, what would I be doing? I would be saying, I want more rotation to this tooth, mesial out. I want to not only make it straight, but I want to go 2 to 3 degrees overcorrected on that tooth. I want to try to continue to align the lower 7s. Okay, get those mesial marginal ridges to coincide, and maybe continue to extrude the upper right 7. I'm pretty happy with the way that the front teeth look. It's a little bit insufficient amount of overjet here. So I might at this point say, hey, the patient needs to continue to wear class 3 elastics, because there is still some class 3 in this molar relationship on both sides, actually. So some class 3 elastics, or maybe at this point, rather than rely on the patient being compliant, maybe we just go ahead and start doing a little bit of posterior and anterior IPR in the case, just to help me get into a class 1, solid class 1 occlusion in the back, and also to retract the lower anterior teeth to give me a little bit more overjet than what I see here. Okay. So, if the patient's willing, and the doctor's willing, and the parents are willing, and everybody's willing, there's still some things we could do. There's some things we could do in the revision or refinement stage to continue to dial this case in. There's a lingual view. You can still see the molars are a little bit class 3. The leveling, those lower incisors are still a little bit below the curve of SPE, so we could continue to extrude those a little bit. But when I look at the occlusion, it's pretty well coupled in the front there. I'm happy with the way that the front looks. But if we're going to continue with the aligners, you could certainly extrude those a little bit more in the lower. Okay, so you can see that key tooth that started real rotated, that upper right 2 was not completely corrected. And, that's the weakness of the aligner. The one that needs to rotate the most is going to probably need some overcorrection and some additional aligners at the end. The key tooth in the lower, that lower bicuspid, or that lower cuspid, actually looks really good. I think it was corrected very well. So Don says here, when is a case finished? Okay, we got these 5 different treatment choices. Patient's tired and they're happy. Well, the patient is tired of the process and demands removal, even if the teeth do not look straight. 2, patient is satisfied, the teeth look straight to them. That's probably what happened in this case. Okay, patient satisfied, teeth look straight, even though you can tell that upper right lateral is not all the way straight. To him, it looks straight. Staff is satisfied, you're satisfied. Number 5 is you can't see another thing to continue to correct, right? Which is the passion. And so this case definitely wasn't finished to that level. It was probably finished to about this level. And I'm going to guess that even the staff was pretty happy with this one. And I would even be fairly satisfied with this as well. Okay, I think it's a good result. Okay, there certainly are some things that could have been better. McGann's comment at the bottom, I was looking at this case again. The scan taken recently is a very acceptable finish in most practices, and goals have been met of correcting the crowding. When making the decision that a case is finished, you had to consider many factors, including the motivations of the patient. That's a huge one. It's okay with me to call the case finished, but if you want to continue for your own personal satisfaction, the patient may not see any changes, then I'm happy to continue working with revisions or brackets, let me know. And doctor and patient decided they were done. So Dr. Chen said, I was ready to finish, so removed all the attachments. Then was a little concerned about the slight class 3, not sure if further growth would affect his occlusion. But if you've ordered the unlimited aligners, and the patient does have a little bit more growth or decides they're unhappy with little things about the case, no problem. We have 5 years and unlimited aligners and unlimited revisions. So we just go in and keep working. If the patient's 6 months later, like, hey, I'd like to keep working on it. Great. That's why I order the unlimited product. Dr. Chen said, I'm happy with the result. So it's okay to send and have the retainers made. McGann said, yes, go ahead and order retainers, assuming that does not stop the 6 or should be 5 years of unlimited trays. If he gets more growth and you have to restart, you can certainly do that. So congratulations on a nice finish. Okay, if you had gone with a progressive 20 or a progressive 30, because remember the first set of aligners was only 28 aligners long. So you could have potentially gone with a progressive 30 and saved $200 or whatever the difference is between that and the unlimited for this case. But for me to feel good and sleep at night, I would personally want to have the unlimited one so that I know that no matter what happens, I'm covered for 5 years on this case. But, you know, realistically, that could have fit in the progressive 30 product because it was only 28 aligners to start. It would not have fit in the progressive 20. Okay. But had I gone ahead and ordered the retainers, that would have closed the progressive 30 case. So there would have been no potential for further treatment after that. So just highlight the finished pictures here because I do think it's a nice finish. I think it's a beautiful case, even though we could pick out a few things that we might have continued to work on if we had more revisions coming. Okay, so there's the views, anterior, left and right lateral views. There's the before and after scans. So you can see how this upper arch has got a very nice arch form compared to the start. Lower, nice arch form. Teeth are straight. I mean, really everything looks very, very straight except for that upper right lateral that didn't quite get corrected all the way. Okay, there's the same thing, but before and after photos. Again, you know, to the patient, to me too, that lower arch looks amazing, looks very good. The upper arch also looks very good. Like everything looks perfectly aligned. It's just that one tooth that didn't get all the way straight. But when you look at the photo from the front, you know, it doesn't really jump out as you as being something that didn't get straightened. It looks great, which is why the patient's happy. Okay, and there's his before and after profile. Was there a change of the profile? You know, he definitely has had a little bit of growth. You can see a little bit stronger chin. May have been just a very slight retraction of the lips based on the fact that we did some expansion. He does look a little bit more full in the start photo, but when I look at that nasolabial angle, it looks unchanged really to me. So the change in the profile probably has more to do with a little bit of growth of the mandible, but maybe a little bit from the expansion that caused a little bit of retraction of the anterior teeth, but that was really minor. But here's the before and after smile. Again, his teeth didn't look bad at the start, but you know, they look beautiful now. And his chief complaint of that shifted lower mandible, now he's centered, you know, and he doesn't feel his jaw shift when he closes down. And that was a chief complaint. I'm very sure he's very happy with the fact that when he bites, his centric occlusion feels like it matches his centric relation. He doesn't bite and feel his jaw shift, which is what he was sensing and feeling. Okay, you know, Dr. McGann loves the final lateral ceph, so he can do overlays. And a lateral ceph and final wrist x-ray were requested to see his growth stage and to do an overlay, but those haven't been obtained yet. So thank you guys for hanging in there a little bit longer than I anticipated, about 20 minutes longer than I had anticipated. But I think this is a great case, and I think we talked about some really important orthodontic principles and some really important things that that you have available to you with progressive aligners. So at this time, I'd like to thank Don and Amit and Dr. Chen for providing this for us. And thank you guys all for being here with us. And I am happy to spend a few minutes answering questions if you guys like to ask questions. So either you can unmute, it looks like there's only like 35 of you on, so feel free to just unmute yourself and ask a question straight up, or a comment. If you have a comment or you want me to go back and look at something, I'm happy to do that with you. Or I'm keeping an eye on the chat here. If you want to type something into the chat and ask a question or make a comment, I'm grateful for that as well. Thanks, guys. I appreciate the nice comments over here in the chat. I really do like talking about this stuff with you guys. And, you know, the part of me that wants to tell you everything I possibly can makes me want to go 4 hours instead of 2. So thanks for putting up with me kind of going off on some little tangents there. But I really want you to see just how much is available to us with these aligners. We're so happy to be working with such a great partner in manufacturing these aligners for us. So any questions, anything anybody would like to ask or want to go back and look at again, or comments, or
Great job, Collins. You did a fantastic job. You're so much better. You're gonna be a hard act to follow on the next one.
I don't know, Don. I could listen to you for hours and hours. I love hearing you talk ortho. So yeah, and next the next webinar is going to be Don. Don, you want to just tell us a little bit about your next one coming up and when that's scheduled?
Oh man, you put me on the spot.
I got it here if you want me to.
August
August 25th.
26th, I think it's a Saturday, 3 p.m. Pacific time. I know that.
Yep, the 26th at 3 p.m.
26th, so
that's
for internationals, just look at Los Angeles, and that's going to be the same time zone.
So for Australia, that puts them in what, Sunday morning?
Yeah, Australia would be Sunday morning, 8 a.m. I think.
Yeah.
So about the case, it's going to be a comprehensive case. You just saw 65 slides. This is 100.
Yeah. Well, I actually had 80 something there, Don. Let's see what I had.
Yeah, okay.
I ended up with like 80 or something.
Yeah, because you were adding. Well, I've got 100, so
yeah.
well, I'm figuring 3 hours. But you know,
Good luck.
So, but no, it's going to illustrate that progressive aligners is designed around comprehensive ortho, not just straighten a couple teeth and a couple arches and whatever the bite, just straighten a couple teeth, like some of the companies were like designed for, really. And that was their whole market. It was just, you know, if you have a little relapse, we'll send it to us, you know, we'll make some trays to re-straighten it.
I think your next case has got some pretty solid rotations and quite a curve of speed that's needed a lot of intrusion to correct. Like there's a lot of stuff going on.
Oh, there's intrusion, there's gingival splay, I mean, this is full on ortho.
Yeah.
And I'm not, you know, but that's what we're about. So that one there is going to be, it's going to be talking some full ortho here. So it's already been laid down, a lot of the features of the you know, of the software and the progressive aligners. But now we're going to be going into more of like finishing aligners. You want to make a bunch of wire bends, or do you want to you know, sit down and write down all these little rotations you want overcorrected, and then get an aligner to do it for you. There's a lot of action in this case.
Yeah. So the next one so your second one you're doing after this next one, so about a month from now, is going to highlight a hybrid case where it starts with brackets and then use a finishing product to finish with aligners. That'll be good to see.
Oh yeah, I've got a couple of those now worked up. So we'll just have to figure out where they fit in. But
so you're gonna all
for a good show.
You're all going to want to stay tuned, whether you can catch the live session or whether you just go catch the recorded version after. I'm really looking forward to hearing Don teach these next couple that are coming up, and hopefully you can join us. So thank you guys for being with us. It doesn't look like there's any additional questions, so thank you.
Doctor, one second. Yeah, this is Dr. Rajkumari.
Yeah.
Doctor, I have one small doubt here. Because initially you have designed the aligner according to the MIP. I mean to say, the lower mandible is shifted to left side. Okay. After 4th month, I mean after the 10th aligner, you showed the picture saying mandible is shifted to the normal position, and then you showed open bite in the posteriors.
Right.
Okay. Already you have designed the aligners. Do you think that particular time you will change the attachments to bring the posterior occlusion in proper alignment, or we will continue the same thing?
Yeah. Do you remember how I showed you that in the setup, they were shifting the mandible at the very end?
Yes, doctor.
Yeah,
that is due to because of the elastics you told.
Right. So they're shifting the mandible because we're telling them to. We said, hey, we anticipate the mandible shifting back to center. So please demonstrate that. And so they're demonstrating that at the end, and in that final position where the mandible is in a corrected position, all of the teeth are lining up properly. So I know that they've programmed the correct movements into the aligner to get everything to look good with the jaw shifting back. But at that early stage, I don't expect to see it fitting together properly because the aligners aren't done yet. So even though the patient's mandible has shifted back over, I'm still early in my aligner setup. I know that they've set it up properly to where by the time I'm done with my aligners, they should have moved all the teeth, inside the aligners to where it fits together properly at the end, because they demonstrated that at the end, it does fit together properly. That's the purpose of that final jump, is to show you, here's how it will fit together at the end if the patient does have this shift corrected. And so the patient corrected the shift early, and at that stage, the aligners weren't done yet. So it's not going to fit together correctly, even though the patient had corrected the shift at that point. So I would have just continued treatment just like what happened, because I know that my aligners are going to continue to position the teeth such that they should fit together better or ideal at the end. So I'm just going to continue on through treatment, trusting the process. And if when I get to the end, I'm not 100% happy, then I'm going to do, a new scan with a new bite, because now I have gotten rid of that shift. Now I can dial in those little final, movements, that kind of what I call the putting, just to get the ball in the hole at the end. But because they provided me that final shift, I can trust that the aligners are going to be continuing to move the teeth in the right direction to make it all fit at the end. Does that make sense?
Okay, let me just add something. I think that would help you with that question. First of all, we're saying that that we feel that it would be best to have a revision. In my way that I look at this, or actually it's refinement, since he made it through all the trays. But if, and in that, let's say they had decided on the refinement, you first need to do an occlusal adjustment. That's something we didn't mention. In all these functional shift cases, right now, before taking the next scan to send in for submission, you have to get out that articulating paper and grind in that bite. I mean,
Absolutely.
grind it in, not just a little teet teet. No, grind it in, and then take your submission a scan, send it in, and then, oh yeah, all that open bite, you can get all that closed. You get all that closed.
That's an
But it's
excellent
just,
point, Ron.
and you get the class, all those things, interdigitated and everything else. It's just a matter of how much effort can you put into it with agreement with the parent and because this is a compliant case. Aligners take a team. Okay, it takes the patient to be working for you. If you put on brackets, which is the other choice too, put some brackets on, and now you can run vertical elastics and all kinds of stuff here, then you'll get them together as well. So, there is a practical part about this, and in POS, we want to show you the whole thing, not just, this is what happened, period, on this case. So so as I said, the doctor and the patient looked at each other and said, "Are we going to go for more?" And they said, "Nope." Okay. So what are you going to do? No. So, in my hands, I'd be arguing with them. I'd be giving them a big argument. They would probably not like me when they left the office, because I'd be arguing with them. I'd make them sign something,
Yeah.
But no, I think the biggest thing right here is that the missing step is the occlusal adjustment.
Yeah. So that's a good point. Anytime that you do a revision on any case, if you're going to do a revision, that's a great time to reevaluate the anterior tooth anatomy. So if you have uneven edges, and if you didn't correct that at the start of the case, whenever you're going to do new scan and send it in for revision aligners, please see if you want to adjust anything with the upper and lower 3-3 as far as the anatomy to make it look better. And then if you had a functional shift and the bite has changed, get out that articulating paper, and like Don said, try to grind it in and try to get as good of a fit as you can, get as many contacts in the posterior as you can before you scan, so that now you're starting this next set of aligners from a much better position as you try to fine tune and finish it up. So that's a really great point. Thank you for making that, Don.
Can I ask another question, Dr. Collins?
Sure.
And it'll be directed more towards Dr. McGann, because I'm dealing with a case in my practice right now where the 4-6 was extracted long back. and I'm trying to mesialize 4-7 into the space, whereas I can see that the residual ridge is quite thin. So my question is that, is it a possibility for the aligners to bring about that model, that bone remodeling, and get that 4-7 into that space of 4-6? Since we say that the slower the movement, the bone remodeling does happen, but are there any chances that aligners can also do this kind of a bone remodeling?
They can bone remodel, but they cannot do what you're asking.
I
They're
agree.
too flexible. They're too flexible for you to be moving a molar forward. There's too many unwanted tooth movements. Okay. I'm
You're just
sure
going to see a tip.
you have tried that with some 1925 stainless steel UP molar bands on the molars. And if you've ever tried that, that works. Okay. But a unilateral one, well,
You need skill anchorage.
that's a challenge. Okay. But I mean, it can still be done. But most orthodontists would say that cannot be done. Okay. Now, to take an aligner, it would be like doing that job on an 016 NiTi.
Okay.
Yeah, it's just too
Impossible.
flexible.
Impossible.
Yeah.
It's at the end of the aligner, which is the most flexible thing. Like sometimes, like on those lower 7s, you were showing how the crown was tipped distal. I've got cases where we couldn't get those to straighten up, even though we had attachments and everything. And
It's too flexible back there. Yeah.
So it comes down to the end of the aligner, and now you're taking out another tooth, making a long span, and now you've got an impossible job. It's just not going to happen. Now, if somebody's insisting on an aligner, sure, give them an aligner with the agreement that you can change the brackets and finish the job.
Yeah, I agree.
Okay. So in this case, yeah, are you suggesting, Dr. McGann, that if the aligner doesn't work, I should put the brackets on and hope for the 1925 to do the job?
Yeah, I'm telling you that the aligner will not work.
Okay.
Under any circumstance.
Okay.
Skeletal open, skeletal closed, skeletal sideways. You're not going to move a 7 into the 6 space. Okay, wait a minute. Excuse me. You can, if you're willing to go through 150 aligner trays, okay. How long is that going to take you? Right?
Probably 2 to 3. Yeah.
Yeah. If you're willing to spend 3-4 years doing this with aligners, okay, maybe, because eventually you'll get it. But anything over 100 trays, forget it. It's not an aligner case.
Okay.
Yeah, agreed. Thanks, Don.
Okay.
Yeah. Thank you so much. Thank you.
Thanks for the question. All right, guys, we're going to go ahead and end it. Thank you so much for being with us. Appreciate all of you. And thanks for your positive feedback there. Thanks for being with us, Don. It's so nice to have you with us. And I know you're taking time out to be with us. So appreciate that.
Oh, well, thank you.
All right. We'll see you all in a couple of weeks for the next one.
I'll be there.
All right.